Where's everybody?
How are you?
Good, and where's Sarah? I could not go to sleep till like 2 in the morning, and I was just like wide awake.
Okay.
All right. Good morning. Happy Monday. This is somewhat of this is Kim McCoy-Wade from California Department of Aging here at our Master Plan for Aging Long-Term Services and Support Subcommittee meeting number 8. This is definitely a milestone meeting for many reasons. One, in the morning we'll be doing our last kind of deep dive, finishing up the IHSS conversation that was so thoughtfully informed by the CDSS listening sessions and, of course, all the work that many of you have put in on the public and stakeholders and so many more with written recommendations and discussion. But then we'll have a brief lunch break, again supported by the Funding Collaborative that's been funding our work. So thank you in advance to the growing number of funders. And then in the afternoon, we will have the wonderful privilege of engaging with the first draft of the stakeholder report that many of you spent many hours, and it is hot off the presses as of, I believe, 8 a.m. this morning is when? 1:30 a.m. Oh, my goodness. Oh, my goodness. So I'm sure you've all read it fully since the 1:30 a.m. So we will, this afternoon, both spend time walking through it. Well, first we will spend time appreciating and celebrating the fact that it exists. Then we will walk through the content, and then we will also be sure we talk about process, both today and in the coming days and weeks, to move this to SAC and, of course, then move it to administration submission. Let me ask on the fly a question I probably should know. For people on the phone, how would they be able to see this report by when we take it up this afternoon? Are we getting that posted at agency? Okay, so our colleagues at agency will be, if you're at home, it may not be posted on the agency webpage just yet, but that is our goal, to have it up by the afternoon so that you can follow along when we do. And those of you who are here, we attached it to the committee members meeting invite, and then of course there's hard copies in the room.
Oh, they copied it, okay.
Any other opening comments before we go to introductions? All right, with that, Carrie.
Hi, I feel like we all know each other now. My name is Carrie Graham, and I'm acting as a consultant to CDA.
Kim Rutledge, California Department of Social Services, Adult Programs Division.
Debbie Thompson, Deputy Department of Social Services, Adult Programs.
Hi, this is Ellen Schmeeding, and I'm here representing St. Paul Senior Services and the California Commission on Aging.
Craig Cornett from the California Association of Health Facilities.
Susan DeMorris, Alzheimer's Association.
Lydia Missilidis, CADS.
Karen Kiesler, CAPA.
I'm Brandy Wolf with SEIU Local 2015.
Catherine Blakemore, Disability Rights
California. I just want to add my appreciation to everyone who worked on this mammoth undertaking, and particularly Susan and team that put it together over the weekend. So congratulations on getting it done.
Oh, 1:30 a.m.
Thank you, Marty, for the
Yeah, sure.
I don't feel tight.
Claire Ramsey, Justice and Aging.
Donna Benton, University of Southern California.
Oh, Anna cannot make it.
Marty Moto, family member, CDCAN, California Disability Senior Community Action Network. Also, just want to do a shout out to everyone the staff who put together that research subcommittee meeting on Friday. The sound quality, the presentation, everything was fantastic. And of course, the information was great too.
Peter Mendoza, consumer representative, and I just wanted to add my thanks to everyone for all your hard work.
I'm Paul Dunaway from Sonoma County Human Services. I'm here in place for Karen Feast.
And you also are in Sonoma County.
Oh, I'm the division director for our Adult and Aging division, as well as the director for our Area Agency on Aging.
Oh, okay. Patty Berg, former state assemblywoman and former Area Agency on Aging director for 20 years.
Nina Weiler-Harwell, AARP. I can't say enough good things about everyone that worked so hard to put the report together. Thank you.
Jeff Hum, California Council of the Blind, and I echo that sentiment. Amazing work, everybody.
do we have subcommittee members Zooming in? Can they introduce themselves? Okay. Just checking to see if we have subcommittee members on the phone. Please introduce yourself. You're unmuted. Who do you see? Can you read the...
Dr. Arvalo's on the phone. We've got Maya Altman.
We are not yet hearing you, Maya Altman and Dr. Arvalo, so we will keep trying on our end if you can keep trying on your end. We're going to keep moving, but don't hesitate to interrupt to introduce yourself so we can know that we're connected. Ironically enough, the next slide is meeting logistics. As I mentioned, the materials are posted with the late-breaking draft that was finished overnight. We're hoping to get posted this morning, so we all have it in front of us for this afternoon's discussion. Reminder: the Zoom info, all information is posted on our agency website, and there'll be public comment at the end of this meeting, as always, as well as. Actually, let me double check. I think we have public comment twice. We have public comment at the end of the IHSS discussion this morning, and then again at the end of the report discussion. And as always, emails and recommendations are welcome, and accommodations for full inclusivity are provided. There's a very detailed agenda. So grateful to the IHSS team who has been so thoughtful in both at CDSS and stakeholders in bucketing is our verb these days, bucketing the IHSS issues, bringing 3 to us today as part 2 from part 1 was just a few weeks ago, it seems like. But here we are, part 2, disasters and emergencies assessments and accessing and directing IHSS services. So really looking forward to a robust discussion on IHSS this morning, and then again, the report discussion led this afternoon. Yes, please.
One thing that we want to add, probably the last 5 minutes of the lunch break, is that Susan, Kim, and Maya want to do a 5-minute update of report back from their Mountain View session. So we're going to make the lunch break about 25 minutes and put that in.
The teaser to get you to for the listening session organized by the Alzheimer's Association with Supervisor Joe Smitty, and very powerful, and we'll share more.
Oh, great.
Just a reminder, in case you had forgotten, where we have been in terms of kicking off in October and running through the deep dives on topics, and now turning to the report. Thank you for your endurance and persistence and getting us to this amazing point. And again, reminder of our meeting guidelines. These are the meetings where we seem to have the most to say, so we are doing our best to start and end on time, one person at a time. The microphone, thank you, Marty, for mentioning the different rooms have different sound challenges. The microphone is really important. Can I be refreshed? This is the microphone for the room, and this is the microphone for the phone.
That's correct.
So people should have that on green. I might suggest, if you're comfortable, leaving it on green so that you're always picked up, but then know that you're always on the mic, so that we can try to make sure folks who are not in the room are able to fully hear us, as well as the captioner. Try to be fully present. We will all be, I know, juggling, but try to be present and use respectful language, especially as we start to move to areas where there might be disagreement and different perspectives. That's okay. That's what we're here for, but please be respectful, and remember that we are all here for the good of people we serve and for California, and are doing our best. With that, Carrie and Team IHSS, are you ready to take it away? Carrie says she does not have much to say.
I think we're ready to
Step in.
Hand it to Karen and Brandy. Are you, Karen and Brandy, ready for the mic?
Voila.
Oh, there's one down there.
Turn it on for you. Oh, wait.
Ask and Lydia provide us. So I was driving in this morning, and the car in front of me stopped immediately. I was baptized with my coffee.
Oh.
So I'm sure that our meeting today is going to be particularly blessed. For the IHSS topic, we went through the summary that CDSS had provided at the last meeting to hear what the reoccurring themes were from their listening sessions, also read the transcript from the December 17th meeting, and then virtually all of the recommendations that had been placed in the Dropbox for the LTSS subcommittee to see what the reoccurring themes are. There are a lot of different points of view on IHSS, but we could see there are some very specific areas where people have focus. Let me say also in terms of the agenda that Christina Boss-Hamilton can't be here.
That's not me, right? Sorry, Karen. It's fine.
Go.
Continue.
Christina Boss-Hamilton can't be here today, and so I'm going to do the launch into what our topics are today, and then Brandy is going to do the wrap-up that was on the agenda for Christina. So we saw 6 big buckets because we are bucketing in this subcommittee. In disasters and emergency response, the need for backup services, and in that bucket people have talked about natural disasters, the public safety power shutoffs, fires, and the need to have emergency backup. There's been a lot of discussion about workforce at previous meetings, the need for statewide bargaining, that there's low wages and little to no benefits, a lot of recruitment challenges, talk about differential and tiered wages, and then also issues about unfair rules that affect parents and spouses for in taxes. In IHSS financing, we've seen 2 big repeated themes. One is to repeal the 7% across-the-board cuts, and also to address the long-term sustainability of the IHSS program. There's been a pretty high volume at a number of the listening sessions and at the different meetings about public authorities and concerns about their capacity to respond with registry services, and a consistent expression that consumers should be able to rely on the registry list to be able to get a backup, to get a provider. There's also a theme around assessments, simplifying them, talks about presumptive eligibility, consumers that don't have changes in their circumstances, improving consistency across counties, and decreasing social worker workloads. And then finally, in the area of consumers that have difficulty with self-direction, that may not be the best way to put that, but consumers that have difficulty with their employer role, and supported decision-making, need for case management counseling, addressing advanced pay, and protective supervision. So across the spectrum of the agendas, a number of those things have been discussed in detail. The area where we felt additional discussion would be good is in disasters and emergencies, the public safety power shutoffs, fires and emergency backup, in assessments, consumers whose needs haven't changed, and so forth. And then finally, accessing and directing services for consumers that could use more assistance with their employer responsibilities and so forth. So our first moderator is Paul Dunaway, and I'm so thrilled that he's here from Sonoma. They've really been at the eye of the storm the last few years, really literally, with the public safety power shutoffs, with the fires. Karen Thies, who's been my partner through this process, she lost her home 2 years ago. So Paul's going to give a little bit of, talk a little bit about some of the Sonoma lessons and takeaways from that. And then just like December 17th, we really don't want heavy presentations. We want a dynamic discussion of the committee to talk about your values, your ideas, your concerns, and so forth. So with that, Paul.
Yes, thank you very much. First, just want to comment about my appreciation of having this topic and being considered into the master plan for aging.
Louder.
Louder.
You have to talk right into it. Hold it right to your mouth.
Up here?
Yeah.
Is it better?
Yeah, that's better.
All the way up here?
Yeah.
Okay, good.
You should pretend like it's your lunch.
Okay, there we go. Yeah. Eat the microphone. So In the last several years, California has experienced several natural disasters as well as planned safety power shutoffs, otherwise known as PSPS, leaving older adults and people with disabilities, including IHSS consumers, particularly vulnerable because they may have impaired mobility, diminished sensory, chronic health issues, lack of social and economic resources. Older adults and people with disabilities are at greater risk of injury or death during an emergency. Last fall, Sonoma County had its second fire in just 2 short years. Compounding the danger, we also had 6 planned power shutoffs, 2 taking place during the actual fire. Many county and city staff diverted from their regular work at several points to contact and address the emergency needs of so many individuals in our county. To give one example, during the power shutoff on October 9th, 2019, 66,000 homes were impacted. 3,949 individuals with medically fragile needs were identified from 3 lists: IHSS list, PG&E's medical baseline, and Medicare recipients with electrically dependent medical devices. 1,419 calls were made to the most critical and urgent individuals, and several home visits were made to people's homes to deliver food, water, and battery backups. One of the power shutoffs lasted as many as 5 days. The largest shutoff impacted 93,000 homes of approximately half of the estimated units in Sonoma County. During the fire, 200,000 of our 500,000 residents were evacuated. For anyone responsible for managing activities during a disaster, it is imperative to think about disability broadly. Traditional narrow definitions of disability are not appropriate. The term disability does not apply just to people whose disabilities are noticeable, such as wheelchair users and people who have visual or hearing impairments. The term also applies to people with medical needs or emotional and psychiatric conditions. It may also include significant allergies, asthma, or respiratory conditions. I also want to emphasize language barriers can also impede someone's ability to navigate during a disaster.
Absolutely.
So a few stories for you. An older couple and husband who cares for his wife, who is non-ambulatory, dependent on a ventilator, and life-sustaining electrical medical equipment. They had limited battery backup to power her devices and can't afford a home generator. Unsure how long the power shutoff would last, they were forced to call an ambulance to transport her to a hospital. The second is about an 81-year-old with significant functional limitations living in a second-story apartment. She requires twice-a-day nebulizer treatments to breathe. In order to continue her treatment when her building's elevator didn't work during one of the 6 PSPS events, her caregiver and volunteers carried her up and down the building stairs twice a day so she could receive power to power her device. So what can we do? Several options. Preparedness would be the first. It's important that all older adults and people with disabilities, including IHSS consumers, be prepared and have a personal emergency plan. These plans should document what will be needed in case of an evacuation, medications, medical equipment, etc., and should contain 1 or more emergency contacts, a phone number for individuals to call. Older adults and people with disabilities should also have an emergency go bag with a copy of their emergency plan. They should also participate in training and evacuation drills as if it's woven into the fabric of our culture. I know this already happens, but county workers should encourage very robust emergency plans for all IHSS consumers. Having gone through 3 emergencies in the last 2 years have opened my eyes to what is really needed in case of an emergency. Second recommendation is collaboration. Coordination, communication, and collaboration are fundamental in an emergency. The state should provide a mechanism such as an MOU for collaboration between local agencies, including emergency operation centers, the state, independent living centers, regional centers, and utility companies before and during a declared emergency or power shutoff. In case of an emergency, the collaborative can identify potential impacts and ensure that all individuals are contacted and/or transported to safety. During this contact, individual emergency plans can be reviewed for thoroughness for that particular disaster. Whether it's building their network of support or knowing if somebody needs immediate attention for food or medical reasons. Related to collaboration, I also just suggest adding universal and accurate lists of individuals with needs. I mentioned that Sonoma County culled through different lists. However, not all of them are accurate and thorough enough. Efforts should be made to have one master list that is accurate, up-to-date, and sortable by individual need in case of an emergency. Staffing shelters. It should be a mandate that every county staff member to attend shelter fundamental training or shelter management training as appropriate. Provide funding for such training. Specifically, shelter coordination. Changing mics.
Ooh, there we go.
Now it's too loud.
No, it's not.
Okay, so back to staffing the shelter, specifically shelter coordination and assessing individuals for their access and functional needs. This should also allow for background checks from other entities to be sufficient for allowing healthcare providers to provide the support in shelters. Two more. Emergency backups for providers. Public authorities who already have backup provider lists for county IHSS recipients must have emergency backup systems. However, it should also be available for those that aren't on the IHSS consumer lists during emergencies. And then finally, additional IHSS hours specific to emergencies. Additional IHSS hours should be expected during and after emergencies. This may include emptying and replenishing a refrigerator after a prolonged power outage or for transporting individuals during a disaster. The state could add a set number of hours and timesheet codes for providers working during a disaster or PSPS event. And that concludes my presentation.
Very good. Very good. Thank you. Any
Hi,
questions?
can I interrupt quickly?
Yes, actually, thank you. Let's not interruption at all. Let's welcome the rest of our subcommittee members who are on the call. I believe that's Dr. Avalo, I'm hearing.
Yeah, it's me. I just wanted to let you know, they just told me I can speak now, so thank you very much for allowing me in.
And Maya, are you also with us, and Christina?
Yes, I'm here. Can you hear me?
Yes.
Great, thank you.
Is Christina also with us? I just heard
Maya.
We'll see. So far, I'm glad the two folks we know are here.
Is she not going to be here?
Also on the phone?
Yeah, but,
Do you think they're in the queue, or Christina?
So they might be dialing in.
Okay, all right, great. We'll continue to work with that. Paul, the question I had for you, and I apologize, are those written recommendations, is that, I have a copy of that document, is what I'm asking.
Has that been included? Has that been submitted?
We just got that input on Saturday, so that'll be one of the things. We had the timing issues.
Of course, yes.
About how to integrate things that were recommended today into the report.
Wonderful.
A lot of it is in there.
So okay,
That's good.
so from a process perspective,
That's
and
good.
just, as you probably well know, and
I got his email.
the Department of Aging is working with the Department of Emergency Services now and our sister brother departments at agency on what we can do continuously improve, not waiting for the master plan. So want to have it for both the master plan process, but also for the meetings that we're having now. So thank you so much for your expertise. We know it's been an extraordinary few years, as you know, and perhaps the only good thing out of it is that you now are experts that can share with the rest of the state. So thank you very much. Let's you go. Okay. I didn't see order, but Ellen and then Marty.
Hi, this is Ellen Schmeeding.
I hear you, babe.
I just wanted to say thank you for your presentation. Coming from San Diego, this is an area we've been working on as a local jurisdiction with emergency services really taking the lead. Thank you. One thing I can say about IHSS is it really would help to be able to have access to that information before a disaster hits, to be able to do the GIS mapping and coordinate with first responders. I think that's one of the challenges of the current law is you can't share the information presumably until there's a disaster. By then it's kind of late to do the mapping and the coordination with fire officials. But I really appreciate your comments and really support your recommendation.
Marty and then Peter.
Thank you. Marty Yamamoto, CDCAN. Thanks, Paul, for your presentation. I only paused because this mic is acting kind of strange. So just a question on terms of the recommendations. Is there a recommendation or a process of making sure going back after a disaster or emergency shut-off to making sure that everything worked the way it was supposed to? And if it didn't work, how would you know that? I mean, because that's usually the issue is that someone gets left out, someone isn't contacted, and then what's the steps to correct it? Number two, I was trying to listen carefully, but don't know if I missed it. The list of people, I know PG&E, I was at a meeting when they said that they have a list of all these people and they will make personal visits, which nothing against them, but I didn't really believe them. No. But is that also a list of people who aren't getting services through the state, or is it, people with disabilities or seniors? Because not everybody is eligible, so you'd hate to have that the people who are notified are people who are eligible by either some state eligibility rule or some federal eligibility rule, which I think is not really the way we should be handling this. It's for anybody who's vulnerable that should be notified. And I wasn't sure if your recommendations included anyone and not just someone who was eligible for services. And lastly, the list of workers or IHSS was interesting because not just IHSS, but any direct care service worker in the home, especially. I'm curious, I guess we'll have to look at how you're going to try to obtain that information. You're talking about a list of workers I wasn't sure if that was, maybe that's something we have to kind of drill down on when we look. But that is critical. There's issues of privacy, but also they have their families too. And so how do we deal with all those things? But thanks again for your presentation.
This is Peter Mendoza, Consumer Representative. First, I really enjoyed your presentation. One thing I wanted to point out, as we discussed before, this really does talk about the need for emergency backup services for people who receive direct care, especially during times of disaster or local emergencies. You can have a great plan as a person with a disability, but most of us need support to carry out our plan. Right. So if you live alone and no one's available, or you don't have an immediate place to call for help, if it's a widespread emergency, our home care workers are going to be affected and may or may not be able to respond, or may have multiple calls from multiple people, and then they have to judge who has the most important need. So I just want to talk about that. Planning is great, lists are great, but they can be problematic too if the list isn't updated or if the person's really active, they may not be home. So you might have somebody going to check on someone who, like me, I'm on a list, but it says between 8 and 5, Monday through Friday. I'm usually doing MCIL business. So I just wanted to say it's really important that we have backup support. Also, it's my understanding, I was on IHSS for a long time, several decades, but now I get my home care support through the regional center system, and I have my own supported living agency. I'm not eligible if I call the public authority for assistance because I'm not an IHSS recipient. So those are just some of the issues, and there are more that need to be worked out as we discuss this issue moving forward. And I realize this is an immediate, this isn't something that will be addressed immediately, but this is something we have to work towards medium and long term as well.
You had a question.
I didn't know if I should answer some of Marty's questions. Very, very good points, and thank you for bringing those up. All the way back to Kim's question, there was some later additions I had to this, which was the universal lists that could be culled that wasn't part of the document, so it would be great if that could be included. And then Marty's question about follow-ups. During these events, I learned a new term, which is called hot wash. Maybe you hot. Yeah.
Okay.
Where you have a debriefing after an emergency, and figure out what worked and what didn't work. One of the recommendations I would add that I'm hoping, or I'm insisting that we do in Sonoma County, is to have ongoing emergency disaster preparedness meetings, to constantly be thinking about what can be improved and how we can be better prepared. And then back to Ellen's comment, Sonoma County actually got the authority to share our IHSS lists. We do it on a weekly basis with our local emergency operations center, and we have the agreement that it cannot be opened unless there is a disaster. However, in case of a planned power outage, we know that in advance, and we can do that very important GIS mapping where we have been able to identify the individuals in the most critical and urgent need, that we can do that contact ahead of time.
Hello? This is Maya. Can I speak to you when?
Maya, can we add you to the queue? We absolutely will. Sorry, we'll do a better job of catching up with you.
And Kim,
Thank you.
Jeff raised his hand too.
Thank you, Jeff. Jeff to the queue. Go ahead, Craig.
Yeah, this is Craig Cornett. I thought Paul's recommendations were spot on, all very good and very clear. Two points I would just make. I will just tell you that in the sector where I work, in the skilled nursing sector, there are huge plans. Everybody has to have plans, has to be drilled. Actually, there were 175. There were 3 facilities that burned to the ground in Paradise. All the residents were safely evacuated with no issue. Staff were losing their homes at the time they were doing that. So I think people in many cases are more vulnerable at home in some cases without these kind of backup things than they are in other settings. And so I think that's an important goal for us to get to is drilling and preparedness in general. The other, I would also just mention to you, this is a fact of life in California.
Yes.
And it's going to get, even though it's been a bad couple of years, it's going to get worse. It's not going to go away. So I think as we think about this, there's a lot here. There's a lot to do to make these recommendations work. I think we probably would want to recommend that we tier this a little bit, start with the most vulnerable parts of the state and kind of work that way. You know, every place is vulnerable, frankly, but we know that. The other thing I'd encourage all of you, too, is in your own groups and associations, when you have big meetings, make sure that the people who are running those meetings have an emergency plan, too. Because I will tell you, we had a conference once out in the desert a few years ago when there was an earthquake, and you need to make sure that everybody needs to be prepared for the stuff no matter where you are.
That's a good point.
Thanks. Claire Ramsey from Justice and Aging. I had one comment and one question. One was about whether I really like the idea of the universal list. I'm sure you'll have some. It sounds like the disaster piece will overcome the confidentiality and like personal health information piece. But can I would recommend that we add that people could add themselves. I'm just thinking of all the reasons people might not be on medical baseline, but might be using equipment, refrigerated medications, things that wouldn't necessarily pop on a list, like, so that people could voluntarily add themselves. And then I just had a question, because I know the state tapped IHSS providers to do some work during the last Sonoma fire, and I was just wondering, sort of in your debrief, sort of what was being asked of people. And my understanding is that the biggest piece was like nobody was going to get paid for any of the work, and our providers are often low income themselves, and it's a struggle, and they're also trying to deal with whatever their disaster is. So just understanding like what was being asked of them, and what steps, is it just payment, or is there other pieces that need to be fixed to make sure that they're made whole?
That might be more the state, I don't.
Yeah. Catherine Blakemore, I think one of the things I always observe is the complexity that arises with different systems, and I think Peter did a good job of identifying that. So if you get services from Regional Center, you're not always connected to IHSS, although you can if you're in supported living. But it means sort of better coordination, I think, at the state level about how you get your services, and that regional centers need to have, there's 21 of them, so they need to have their own mechanism for backup, or potentially there's opportunities for contracting, I think, with the public authority to provide some of those backup services. So I think should just go on a list about how do we ensure this cross-department collaboration as opposed to thinking of systems so much in silos, and that there's a fair amount of good work that could be done there. I think my other just observation about facilities is, one of the things that has happened at different points of time is the facilities, in fact, have really good plans, but they all use the same transportation company, and then there aren't adequate transportation companies to actually deliver on the promises they've made to too many facilities. And then the realization that not all disasters are going to be like we need to deal with a fire, but what do we do when facilities are in buildings that are either not currently earthquake safe or the earthquake was different? For example, I'm a Southern Californian for a long time, so I always think about earthquakes, not just fires. The facility is not what was designed to be earthquake safe, but earthquakes are unpredictable, and it results in that. So I just think this disaster topic has so many layers that we always just need to continue to think about it.
Let's just go around here.
This is Brandy with SEIU. I think the 2 points that are sort of sticking out for me is just around some of the recommendations that are coming up for additional services provided by the public authority, for example, just ensuring that there's funding to go along with that. I don't disagree with the recommendation that the public authorities could potentially serve as a resource for non-IHSS recipients in a time of need around emergency backup. I just want to make sure, and Karen, this is probably a point that you would like to make, but that there is adequate funding that goes along with that to ensure that IHSS consumers are receiving that service, and then there's also additional staffing for folks outside of the system. And then just to comment on Claire's question, I mean, anecdotally, we know what our providers told us around what they were being asked to do. It largely was going to the consumers' homes and checking on them, making sure that they, were okay first and foremost, but then, what their level of need was, how the PSPS was affecting them, et cetera, and all not paid. So I think from the union perspective, we would strongly support some of the recommendations around a set number of hours in an affected area, and just assuming that the IHSS providers are providing that service, because oftentimes they're going above and beyond what would even be allotted for that. So,
Karen Kiesler with CAPA. We've talked about, but did not yet advance, a recommendation on how to fast track enrollment or allow payment to a provider that's willing to do IHSS but is not yet enrolled. And this came up not only in Sonoma but also in Santa Barbara with the flooding. So in order to get paid, you have to have gone through a criminal background check, you have to have gone to an orientation, you have to have filled out a bunch of paperwork. And if you can have situations where the consumer's gone one direction in a fire and the provider's gone a completely different direction. So now you have that consumer in an emergency shelter or what have you, and there may be somebody completely willing and capable of providing services, but we can't pay them until they've gone through those steps. So something that's worthy of teasing out is some kind of a short-term, potentially state-only payment for providers that are instantly linked to a consumer in an emergency shelter or some other appropriate setting. When I say appropriate, I don't want it just to be limited just to shelters. We know in our criminal background check data that it is an incredibly low number of providers that are disqualified due to the crimes that are the disqualifying criteria, an incredibly low number. And it would be, I think, controversial to try to get rid of that, and we're not suggesting that. But for some short term, it does make sense to us to have some kind of an expedited, instant sort of an enrollment on the public authority's capacity and ability to provide services to seniors and people with disabilities that are not IHSS consumers. We are authorized by statute to get criminal background checks for private pay people, but the advice that we've received over years from the department is that public authority admin money is for IHSS, just like county IHSS admin dollars are for IHSS. So it would be helpful to have a bit more flexibility, and appreciate very much Brandy's point about also having adequate funding. The last point I want to make is that the public authorities are eager to build emergency response systems. We would want that not to be housed someplace else, not with the counties, not with the ILCs. We believe that an important element of having an emergency backup system is going to be differential pay. That is really, really critical to have people who are available on call and can serve the consumer. And wherever it is that you have that highest wage, that's where providers naturally will gravitate. So if you had an emergency backup system in one place and the public authority registry with the public authority, if those are separated, it will make our job in recruiting providers for the registry that much difficult. Again, because the providers will gravitate to whatever system pays the most. So it needs to absolutely have a differential wage.
Yeah, that's good.
Okay, we're gonna go to Maya on the phone.
And we have about 5 minutes left on the agenda for this topic, so.
Hello? Can you hear me?
Maya, we can hear you.
Okay.
We can hear you.
I'll be really quick. I just wanted to mention that, to remind folks not to forget the managed care plans, which have a wealth of data on people who, especially as Craig was saying, people that are not in facilities. So for example, during the PG&E power shutoffs, we did a lot of data mining to find people who were dependent on certain, devices. And we crosswalked our lists with the county lists, and we're able to, together call or contact people. And I know Partnership has done a lot of work in the, so I just think that's a resource, and, the department and the agency is aware of that, but that's just another, rich source of data for these kinds of efforts. And again, to the extent that, what, as Alan said, to the extent that we can share data and plan ahead of time and then keep updating the list, that is very critical. Thank you.
Let's go to Lydia and then
Lydia Missilides. Great discussion. A couple quick thoughts. I'm kind of thinking about this at the state level and what are some of the recommendations, and then at the local level, because I was really reminded with Catherine's comment and Paul's, every county is different in terms of its resources and mix of providers and transportation and so on. And having from afar been privy to a lot of the effort that went into the during and after fire situations in Paradise and in Napa. I had a couple of thoughts. I wanted to underscore the issue of flexibility during emergencies. I don't think it's clear what kind of regulations can be waived. I think we could maybe ask OES or someone to take a look at that, because in our example with CBAS, a lot of our participants also receive IHSS. It's like all hands on deck, whoever's available in the part of the county that isn't impacted by the fire or wherever you can travel, you make yourself available, but you don't get paid for doing what you're not supposed to be doing, right? So I think that's something globally that needs to be looked at. And then the one example, for example, of waiving regulations, one center in particular needed to do a pop-up childcare because their staff could not leave. There was no school, you understand. So they had to do a pop-up childcare. Worked out great. They found some students that could supervise. Didn't ask permission, didn't have to ask for forgiveness. And then people made homeless from fires. As Craig mentioned, facilities are places, and they have deep requirements for preparedness. And CBAS and an adult day program is a place, and again, could be repurposed, reutilized in a way to support people temporarily who are homeless. Another issue is expediting, as you mentioned, Karen, enrollment in an emergency so that people can access the service that they need without having to go through weeks or months of eligibility reviews. So just a few thoughts to add to the thought process of this, and some of these are state rules that need to be looked at, and ideas and others. I really love your idea of continuing to do post-action reviews of emergency. I know Napa's doing that as well, and every county should be. So thank you for your presentation.
Susan DeMorris with the Alzheimer's Association. We have a broad interest in this topic, larger than IHSS, and we've just been amazed at responsiveness in your county and others in times of disaster for people living at home as well as in residential settings. For this topic, we would put a pin in those who are on protective supervision would warrant additional attention, and especially if they're sheltered. So somebody who's already been deemed to need protective supervision in IHSS, if they're moved to a shelter, they're very likely a wander or elopement risk, and the disruption of a sheltered environment is very difficult.
Good point. You want to make sure somebody state what the engagements are included in the master plan, in terms of waivers and things.
So I just wanted, and it may well be that Sonoma made good use of these folks, but I just wanted to underscore the many uses to which private partnerships with transportation companies like Uber and Lyft can be put. And even for those who are non-ambulatory, because we know that Uber and Lyft do not have sufficient fleets to handle that population, they can still bring out materials to those folks. And I think it's important that when they provide training to their drivers ahead of time, that we hope that their drivers would get some, modicum of disaster preparedness training, so that they wouldn't be basically flying from the seat of their pants when the situation breaks out.
Hi, Nina Weiler, Harwell, ARP. Really appreciate the conversation. I always learn so much from my colleagues here. Like Susan, we do look at a very broad swath of the population, IHSS and beyond. So, again, really appreciated the conversation around a universal list. I also appreciated the recommendation about ensuring that people have a kit and a plan. I'm just curious, and we can have an offline conversation, how that actually plays out and how you keep those plans updated, how you train someone on how to use them. I think that's a great idea, but it's a heady task. And also appreciated Craig's recommendation about kind of triaging the state in terms of where we would focus on emergency outreach.
Okay, I just want to express our gratitude for this LTSS committee lifting up disaster and emergency preparedness with this lens. As you probably know, it has already coming up in 3 places. The community roundtable that we had in Nevada County in December, we heard about at the SAC. We heard a lot about their experience on Acton, and City Council Member Jan Arbuckle were able to present and give recommendations overall. We are also having a webinar Wednesday on this topic. I'm going to say February 19th, with Karen Fees presenting and Christina Mills presenting. So we are doing a webinar Wednesday as part of our security and safety look. And internally, my deputy Mark Beckley and I was calling it a roundtable, but now I'm going to call it a hot wash for sure. This conversation with our Office of Emergency Services about how do we get an ongoing aging and disability disaster table set so that, yes, we're all doing our debriefing on CDSS has the primary food and shelter responsibilities as well as IHSS. Of course, public health has different responsibilities, DDS has different, but how do we learn? So that first roundtable hot wash is coming together for February. So this is extremely helpful to us to continuously improve in our coordinated work. So thank you again for elevating in every table. Are we ready for topic 2, Team IHSS?
Oh, yes.
Claire, I will literally hand you the mic.
Thank you. And I have a question about timing. It says my topic is only 5 minutes. Is that just a typo?
Real quick, please.
Yeah.
Let's make it
I didn't think it's just been.
She talks really fast.
I do, actually.
Almost as fast as me.
Sometimes people have to think that's a bad thing, but. What should I?
You do not need 40 minutes, so you can adjust sometime, at least
Oh,
on Wednesday.
We're an hour and 20 minutes for 2 topics.
And then I know there's a short presentation by Justin Garrett.
Within, yes.
Okay.
He's already at the table.
Oh, hey. How long do you need?
I was told 5 minutes.
Oh, you are real for financial stuff. Oh, you're going to be talking fast. So can I do 20 for assessments? Okay.
Everyone's nodding at you.
Assessments. Okay. Yeah. Great. Thank you. So.
We love
Oh, you guys are awesome. Thank you. So our topic has already gone up. So let me just read the recommendation, which is the real broad recommendation, which is the state should simplify administration of the IHSS program where possible and allow for greater flexibility in the administration of the program. And for a little context, this recommendation is really one that was born out of recommendations coming from several different sources. And I think from sort of one of the things that makes me feel like this is a really strong recommendation is it came out of consumer concerns, it came out of provider concerns, it came out of county concerns. And I'm guessing if the state, I see a slight nod by Debbie, so I'm going to say, and I think the state can recognize where the program has gotten extremely complicated. So for those of you who are not as steeped in the IHSS program, I think what has really happened is as the program has grown both in size and in sort of what it can offer to people, it not surprisingly has just gotten more and more complicated. So some of that comes from good things like, as we mentioned, like being able to provide overtime for providers, allowing for sick leave. Those are all positive developments within the program, but they have just added layers of things that are happening within the program that make it harder for people. So we have a list of about 5 specific recommendations that we've called here, but I think this isn't supposed to be exhaustive. I think the broad recommendation is that the state, county partners, consumers, and consumer advocates, providers, unions would look at these, public authorities would all look at these things and really start to identify where things could be simplified. So I know the pages aren't numbered, but it's recommendation C25, and then there's 5 specific recommendations under that. I will just quickly go through them, but then hopefully people will have good questions and we'll talk about things. So allow for simple redeterminations for recipients with stable conditions. That's something that we heard from a lot of different sources, including from the IHSS listening sessions. Changes of the parent-provider rules to allow for better choice of providers. Right now, I won't get into it, but those rules are extraordinarily complex, probably for a number of reasons, but I think really looking at whether they need to be or not, and whether they serve the population well. Streamlining provider rules to ensure it is easy to hire and pay providers. This is born quite a bit out of concerns that there are delays, especially in the initial sort of setup and movement forward of getting someone onboarded and then paid for the first time. Review assessment procedures to ensure individual need is reflected. Again, assessments are complicated. There has been work in this direction done already. I think it's continuing to figure it out and refine it and to find that right balance between consistency so that what you get in Santa Barbara, what you get in Sonoma, what you get in Butte are similar and not just driven by an individual social worker's assessment, but also that your individual need is being well reflected within your assessment since that is what is supposed to be driving the assessment. And then last, improving the coordination between the IHSS program and institutional settings to assure there are no gaps in services for those being discharged. Again, there are rules in place around discharge already, but you know, there's a lot of ambiguity in those rules, and you know, one of the things we really want to streamline is, again, as we talk about this being systemic and not just a simple, you know, siloed group of programs. Like when you're in a hospital, you're in a hospital, and then when you're at home, you're at home, and who knows what's happening in between those, that things are more linked together. And I think there's a real desire from that I've heard from the hospital side and from the IHSS side. So I think some of it's us just coming together and bridging those gaps. And with that, I will stop sort of presentation mode and see what other things people are worried about, have thoughts about, questions about that we can talk about and answer.
Thank you. Oh, no, not at the moment.
And I saw Donna just going to hand it over.
I would say that for family caregivers, part of the issue comes up is that when people are trying to apply for IHSS or when the assessments are done, that many times the caregiver is not there. And maybe the person that they're talking to may have dementia or something, and they'll just say, oh, everything is fine, and they'll get the hours aren't adequate. So if there is a way to help incorporate some of the opinions of the family caregiver during the assessment.
Is that okay? I'm just going to pass it down.
I'll just intercept it for a second to say one of the things that DRC has that's really helpful, it's on our website, is assessment packet where caregivers or the person with a disability can identify in a written way sort of what the person's needs are, and it's designed to then be given to the social worker who's doing the assessment. So I actually agree it's helpful to have the caregiver there, but sometimes that's just not practical given people have complicated lives, and I'm just offering that as an additional tool that many people have found helpful.
Karen Kiesler with CAPA. I wanted to emphasize one thing and then bring up a new one maybe. It's in the report to address the county social worker workloads, and that is really critical. It is crazy to have expectations that an accurate assessment can be done when you've got caseloads over 300 in a year. It's just crazy, so that really does need to be addressed. The second thing I wanted to raise is about homelessness, and I noted that Dr. Galley at the SAC meeting last week talked about both housing and transportation need to be addressed more in our efforts here. So in the IHSS program, there was guidance provided to the counties back in 2008 that said the IHSS program is to provide services so that people live safely in their home. Living out on the street or living on a riverbank is not, according to this all-county letter, a safe location, nor is it a home. So we definitely do have homeless people with disabilities that would qualify for IHSS and might be able to secure a provider, and yet the program rules, if they're strictly followed, say that IHSS can't be provided in that environment, and that needs to be addressed.
Lydia, could I address that quickly before you? Of course. This is Claire again. I just want to draw people's attention to recommendation C22. It's to promote equity and equal access in the IHSS program. Just to be clear that this was not specifically about assessments only, but we are trying to both lift up the idea that, IHSS serves an enormously diverse group of Californians, and not really surprisingly, given how diverse California is, but that there's needs around, and it's not just within assessments, but around language access, around equal access to effective communication, around cultural competency, and then also trying to reduce barriers for people who are homeless or in unstable housing, because the way I've really come to think about it in terms, and I'm not saying I'm alone in this, but really the spectrum of being fully unhoused and unsheltered all the way to being, stably housed in a home you call your own. There's a big spectrum there, and I think IHSS for a long time was really viewed as like, oh, I'm older and I'm stable and I need this help, and that's kind of what the model looked like. But now as people are couch surfing, coming in and out of shelters, sometimes housed, sometimes not, it's gotten a lot more complicated. And so I really think it's important for us to think about the ways in which the program can be dynamic, and the way that the program also has to be thoughtful about what the needs of someone who isn't housed might look like different from someone who's housed, and what do we do about that. So we do have a specific recommendation around homelessness that we hope you will all think about and consider. And then, just understanding that the IHSS program is big and is serving within it a lot of diverse populations. And so how do we do better by the populations who are being underserved by the program now, just given how complex it is, or who are just being systematically challenged to use the program because that's not what the program was initially designed for.
Lydia Mitsoulides, Claire, that was elucidating some of the thoughts that came up in my mind too, because while addressing homelessness is a multifaceted, very complex issue to address, I don't know that we in the LTSS community are fully connected with those who are really experts and have spent their careers addressing homelessness in a way that could make all of us more effective. And we've had the same challenge with adult day services, in that a person may not have an address. We have found a way to get around, not around it, but we found a way to work within the regulations to be able to serve someone who doesn't have a permanent address. And I could see the value of being able to partner more fully with IHSS. And it also struck me, and others, obviously, care navigators and so on, but it also struck me, seems that person who has an IHSS worker and is someone who we societally would like to prevent from falling into homelessness or unshelteredness, it seems like that individual could also serve as an early warning system for when people are having trouble with money management, paying rent, falling out of employment, whatever it is. And I don't know if there's connectedness right now to be able to really deploy the IHSS workforce in a way that could help with that early warning system. So that was just a thought that came up as some of you were talking. It's an important thing to think through a little more, probably more time than we have today.
And I have more thoughts on that. I don't know if other people want to speak, and then I could just say a little bit to that too.
Thank you. This is Ellen Schmeeding. I just want to share that we don't have a lot of representation from county personnel here, but having been a county administrator with IHSS, we had multiple meetings over years to look at how we could redesign IHSS with white papers. I kind of lost track. I think I was with maybe 3 or 4, but one of the things that always comes up is whether or not it makes sense to do the streamline review for certain populations whose needs don't change. So the one thing I would share with that is that just to be sure that there's some method to check in with vulnerable people. They may be high-hour clients, high-hour recipients or consumers, but just authorizing hours and then walking out without some sort of oversight to ensure their safety, especially individuals who live alone and who are vulnerable. So just a quick point there. And also, I'll get on a soapbox and quickly get off. I think IHSS needs more time. I know there's somewhere in here, I was just looking for it, there's a recommendation to bring a group together. I think all these issues need to get on the table, not just financing, but
the administration of the program. Thank you.
Right, exactly.
Right, we're gonna go to Jose on the phone.
Yeah, hi, this is Jose Arevalo. I'm the Chief Medical Officer for Center Independent Physicians and the Chairman of Latinx Physicians of California. And I want to thank you, Claire, for these strong recommendations. I particularly wanted to point out the real interest that's happening now with, like you mentioned, hospitals and integrated care systems around the communication piece with individuals who have IHSS workers, and being able to do a two-way communication that allows the care management teams that in many instances have been identified for a particular individual who may have IHSS support, and being able to improve the communication with the worker, the caregiver, and the team, particularly the case managers have been identified who are integral to working with these patients and these individuals. And so I really want to accent that and underline that because there is a strong interest and a growing interest by many hospitals and many integrated health systems to be able to improve that communication, which I think in the end will really help not only just the individual and the worker, the IHSS worker, but really the team that's struggling to try to find ways to better do care coordination and improve the outcomes for all these patients. So thank you very much. Really appreciate that.
This is Peter Mendoza, consumer representative. I just wanted to mention in the area of assessments, a person may be assessed for in-home support services, but may need more services because a disaster or an event has occurred. So as part of the initial assessment, maybe talking about, along with having a plan, what you're going to need if you had to be evacuated. For example, in my own personal life, I have a ceiling lift. Okay, so anybody, as long as they're trained, can do my home care because there's no lifting, just a little body positioning. But I weigh about 185 pounds, maybe 190 according to Kaiser. So if I go to a shelter, my PCA is going to be able to lift me, and it'll probably take two people to lift me, and I have a chronically dislocated hip, so it requires a little bit of finesse. The other issue regarding shelters and evacuation is many shelters, including shelters for the homeless, will not accept a person with a disability if they have a provider for home care because of confidentiality or other reasons. So we have people with disabilities who are living on the street because they're not allowed to go into shelters because they need home care, and that really has to change.
Yeah.
Also, the definition of home is sort of changing, and programs need to change their definitions as the definitions of home and family change. And this isn't just an IHSS issue. This is an issue for a number of direct care programs in the state.
Last two comments before we pivot to
Paul Dunaway, and speaking on behalf of county, since Ellen said that should be a topic of interest. So I would always support any sort of concept around streamlining work and providing greater efficiency. Making workloads manageable is always an interest. My only caution is around taking the social work out of the practices of IHSS and wanting to ensure that when we go into people's homes, we're looking at the whole person when we make our assessments. It's not just checking off boxes and providing hours and then moving on. Some dynamic work sometimes comes out of that work. Sonoma County specifically does depression screening, and that's not something that's in regulations, but we have prioritized being able to do that for people when we're already in their homes. I also support the idea of looking at flexible regulations around what qualifies as a home. Homelessness and IHSS recipients could certainly benefit from that. And then the other thing that I just wanted to bring up is social work is really becoming and getting much more popular in the realm of being taking a collaborative approach, whether that's with healthcare providers or what have you. But to be able to do that, I think just takes quite a bit more time, and some recognition around caseloads around that would just be important.
Yep. Nina's going to be our final comment, and then Clary is going to wrap it up.
So just really quick, I just want to echo, Nina Weiler, Harwell ARP, I want to echo Donna's earlier comment about the role of the family caregiver in the assessment. Understanding IHSS is self-directed. Part of that self-direction is, I believe more than half of the providers are family members. So some of that self-direction,
70.
yeah, I was underplaying it. It is 70%. It's a majority. That some of that self-direction is having that family member be there, and that's usually what people want. They want their family members taking care of them, not strangers. So again, where appropriate, making sure that that assessment occurs. Thank you.
Thanks. This is Claire again, just to wrap up. I think we had a good discussion talking about sort of the complexities and the possibilities of involving both family caregivers more and providers generally in assessments, how to connect to managed care and care teams and coordinators, sort of a reemphasis on streamlining thoughtfully and in a way that is supporting a whole person and not simply making checkboxes where we don't include people in their own care. Thinking about disaster planning and how that links to assessments, which is very relevant to our last topic. How to broaden the definition of home thoughtfully and appropriately for where we live now in current situations. And lastly, how to think about homelessness. And I just will leave people with this thought because it's been something that's really percolating in my mind quite a bit these days is, as the homeless population really changes to be older adults and people with disabilities, and a lot of people going into homelessness for the first time after 50, where can we think about IHSS, LTSS, personal care as a possible solution to homelessness and a possible prevention model for homelessness? And I think it's really worth exploring, and it isn't something I think we've needed to think about in the same way, and I think we're now at a place where there's a lot of people actually putting thought into it, and we should be at the forefront of that. And I think California could really be at the forefront of something that might really have national relevance. So, and with that, I will turn it over to Justin for an amazing, apparently, 5 minutes on financing. I'm excited to hear this.
5 minutes.
And in 5 minutes.
I'm just shocked. I know. I can't.
With a happy ending,
You can have
right? I felt like it.
Yeah.
Minus that.
Okay.
Well, thank you so much. That's the clicker? So Justin Garrett with the California State Association of Counties. Really appreciate the opportunity to speak for a few minutes today about the county IHSS fiscal structure. I know there's been some questions and discussions about county IHSS costs and incentives at prior subcommittee meetings, so thank you for inviting me to just kind of hopefully provide some clarity about how things are currently structured and set up. Excellent. Okay. So, as has been mentioned by several county representatives here on the subcommittee, counties are committed to this program, committed to the important work of helping people remain safely in their homes, and really proud of the IHSS program. And so the way, that comes out in terms of our county IHSS costs is counties have a maintenance of effort. So every county has a set specific amount that counties pay each year. There has been several iterations of the MOE. The current one just started last year, July 1st, 2019. And now counties have their set individual amount, and those IHSS costs for counties only increase for two very specific reasons. The first is an annual 4% inflation factor, and the second reason is the county share of any locally negotiated wage and health benefit increases for IHSS providers. So there's no way for county costs to grow different than that annual 4%. And if we look at the next slide, we can see that displayed visually. Maybe, there we go. So counties essentially pay for the share of caseload and hours growth through the inflation factor. But if hours grow higher than 4%, then counties' costs don't grow higher than 4%. If they grow lower than 4% or reduce, counties' costs don't reduce or grow less than 4%. It's a set 4% amount. And so this really kind of shows here, what counties' costs are and then how the state and federal picks up the rest for the actual growth of it. And so there really is no fiscal incentive for counties to, try to under-assess hours or to reduce caseload. It doesn't save the counties money. It doesn't fit with the county commitment with this program. Counties are out there ensuring accuracy and ensuring these services can be received. And this kind of displays how that works in terms of a fiscal sense for counties. And then our next slides just kind of provide a little bit of history. I think it's instructive. There's been so much work done over the past couple of years and 2 huge new maintenance of efforts related to the county fiscal structure for IHS that I thought I'd just provide a little bit of background as it kind of informs the committee fiscal recommendations moving forward. So 2017, when the CCI ended, there was a new county MOE replacing the initial one, and this one included a significant shift of cost to counties, about $600 million. That was offset partially by, some state general fund investments as well as a redirection of growth funding from health and mental health to social services. So we were seeing direct impacts on health and mental health programs because of the increased IHS costs. The other key thing there is there was a required 1991 realignment report to re-examine the structure after 2 years, because we saw after 2 years there was going to be significant realignment shortfalls and impacts across the broad array of programs that operate under realignment. And so Department of Finance, my mic cut out. Department of Finance. Did it get turned off? I think so, but let's try.
Bang it on the table.
In consultation, is that on? Yeah. Okay. So the Department of Finance produced a 1991 realignment report in consultation with relevant departments, counties, IHS provider unions, other interested stakeholders, and really examined realignment as a whole. And so there are some key findings. The reason IHS costs had grown outside of what could be contained within realignment were for factors outside of county control, such as state minimum wage increase and implementation of the federal overtime rules. And so given that, the recommendations were to lower county IHS costs and have a new MOE that was lower so that it would fit within realignment, and then also so that, health and mental health programs within realignment could continue to, or start again to receive general growth. And so these recommendations were supported by the legislature. They were recommended by the governor in his MOE proposal, and they were enacted into law. And so, that really kind of shows that a really thorough examination of this complicated 1991 realignment fiscal structure was done, and the recommendation was to kind of lower costs to fit within realignment rather than try to do some other sort of significant restructuring of realignment itself. So we saw the negative impacts that were occurring to health and mental health programs, and the interested stakeholders and departments and everything kind of came together on this solution. It was proposed and it was enacted into law, and it provides a much more stable fiscal structure for counties moving forward than what we had been facing under the prior MOE. But of course, as we look forward, counties are always interested in the long-term fiscal sustainability of this program. Currently, county share of costs for local wage and health benefit increases is 35% of the non-federal share. When we come to the point when state minimum wage goes to $15 an hour on January 1st, 2022, that'll increase to 65% of the non-federal share. So counties see that as a potential concern as we look at the long-term fiscal sustainability for IHS, both in terms of its impacts on collective bargaining at that point for wages moving forward from there, as well as just the overall ability for the new county MOE to continue to fit within realignment. And so we see that as something that we pointed to in the letter to the LTSS Subcommittee. And, counties are definitely committed to the conversation for the long-term sustainability of this program, from the way it sounds like the recommendation's going to kind of start a work group and a conversation. That definitely sounds like the right approach, so we appreciate that. Want to join and participate in that as much as possible, and certainly happy to take any questions on this structure. I would also point to our website, CSAC's website. We have an IHS page. We have some really good resources up there that explain how the county MOE amounts were determined, have a real deep explanation of all the complicated wage and benefit tools and things like that. And so encourage you to check those out, and certainly happy to take any questions. Thanks.
I'm sorry.
Okay, I think Randy has a question.
Hi, Brandy from SEIU. I would just flag this is of particular importance around the union's recommendation to move to statewide collective bargaining. We sort of see this shift in county participation of the non-federal share from 35% to 65% as an absolute, like, death cliff for us in collective bargaining at the local level. And so, particularly because we feel like 2022 is going to be here before we all know it, having a real conversation around statewide collective bargaining in the short term is a number one priority for the union. So I just want to flag that for this group and really for the full stakeholder committee.
Thank you so much. That was extremely helpful. And so I really think this is an important time. I want to clarify on page of the report, it's under recommendation D2 where it talks about aligning state, county, and it also mentions health plan financing, but this is really more about the state, county. So it sounds to me like maybe, is it true that prior to the 2019 revisiting of the realignment, there might have been an issue, was there an issue prior to 2019 that where counties did not have, there was more of a disincentive, but then the 2019 realignment fixed that, or was this not an issue? Because it seems to me that the fact that you have the caseload growth not impacting the county share, then that's kind of addressing the issue that's outlined in this recommendation, and maybe this recommendation, it has to shift its focus away from the state-county component of the financing formula.
Right. So, good question, and I tried to keep it for the most recent, but I could certainly have gone back further with the county structure. So there's been 3 MOEs. The first one started 2012, 2013 with the Coordinated Care Initiative. Prior to that, counties had a 35% share of the non-federal costs for IHS costs from 1991 realignment. And so once the MOE started, then in 2012, 2013, then counties have that set growth. The rate of inflation factor has changed each time with the new MOE, but there's been consistency in terms of counties' costs are growing by the inflation factor and growing by the share of local wages. And again, there was statewide bargaining for certain counties and part of that as well. But so it's been pretty consistent with the MOEs in terms of how that works.
Okay. So that is really helpful, and so I would just recommend that the work groups, we revisit this recommendation. I think that that's pretty important. So, we don't have pages on here, so it's the bottom, second to last page. Oh, yeah, D2.
I'll remember them.
Yeah.
Well, in fairness, I mean, again, you all were drafting before we had this discussion, so that's
Right.
our
That's right.
parallel tracking.
Well, we did have the discussion, but we didn't have this perspective during the discussion. So that's very helpful.
Thank you for that. I've sort of avoided IHSS financing in all these years for obvious reasons. But why did the ratio flip so dramatically in the last negotiation? I mean, I really get what Brandy is saying. That makes sense, but I'm not quite understanding how those ratios completely flipped.
You want to hang on one second?
Sure.
Can I add something? If Debbie adds to that?
So just to make sure, because that people understand, when it flips, the state participation cap goes away. So right now there is a state participation cap where it doesn't participate over minimum wage plus $1.10. So for those counties that are paying a higher wage end, when they locally negotiate, they would pay 100% of the non-federal share. When it flips, the counties will still get state participation at the higher levels. Okay, so state participation goes away. There is no further cap. Okay, so that's one of the changes. And a part of the renegotiation of the MOE and looking at financing was looking at who had the most control over the increases. So, for instance, the control with minimum wage going up, that was a state law change. So the state pays 100% of those costs.
The sick leave benefit, that came 100% to the state. So it was a part of that financing and that flip was because who's negotiating has more control over those costs. Not saying how it impacts the whole bargaining thing. I'm just kind of trying to share some additional perspectives of how they arrived at that. The prior to MOE, where the cost sharing was, the counties had 35% of everything, right? So you had 35% of all the hours increases and those kinds of things. At the administrative side, they had the 30% of the costs were the counties. As a part of the new MOE in the 1920 year, the administrative costs now are the state pays 100% of the non-federal share up to that allocated amount. So the counties don't have a cost of administration unless they go over that allocation. So those were some of the changes that occurred also, just from a perspective point of view.
Yeah, these discussions are helping to answer my question. What I'm trying still to understand is what would happen with the shift of bargaining to the state level? Who would be paying for those increases that would be negotiated if there was one single negotiating group at the state level?
I mean, I think that would be up to however it was enacted and discussed among the stakeholder and the state and everything else. And certainly from the county perspective, kind of consistent with what Debbie just outlined, if it went statewide bargaining and it was within the state's control over wages and benefits, we would, not want the county costs to be reflective of the lack of control that counties would then have over that. So we want it, of course, to consistently still fit within realignment.
So thank you for the presentation. It's helpful. The other comments were helpful as well. So I'm looking at this bullet that says on January 1st, 2022, or the state minimum wage reaches $15 an hour, state participation will decrease to 35%, and counties will be responsible for 65% of the non-federal share of cost for wage and benefit increases. So it's almost, are you what?
Sorry.
I'm really just trying to understand that, given what the state just said about how it's working. I mean, they almost seem inconsistent to me. So do we all agree that's what's happening? The counties are going to be responsible for 65% of for only local increases and not the state minimum wage increase. Is that right? And do I get it now?
That's
okay,
correct.
then I'm clear.
Well said.
This is Maya. Can I ask a question or get in the queue?
Yes. Why don't you just go ahead, Maya, and then we have Pat.
Okay, how does this work with the, contract mode under the MOE? Is there, because I just have a question that was just posted, so I'm just echoing the question that, is there a further disincentive for the counties to use the contract mode, with this new arrangement, or can you enlighten us on that?
Yeah, and then if Debbie wants to, I mean, essentially, it's similar. Counties pay for increases in wages and benefits through an adjustment to the county MOE. And so for increases in the contract mode or new contract mode, there's a similar process where there's an MOE adjustment. So that's a cost that gets added to the county MOE that's paid every year, remains part of the MOE, subject to the annual 4% inflation factor, in the same way that a wage increase or a benefit increase.
So there's no particular disincentive for the county?
Different incentives than
for the contract mode.
It happens in a similar way. Okay. I mean, whether it's
similar
wages and benefits under agency or whether it's wages and benefits that are individual providers, there's a similar increase. Maya, did you hear all that?
Sorry. So, and we can go into, it's complicated, so giving all of the detail is, but similarly to a locally negotiated wage and benefit increase for providers, if there's an increase to what's being paid for the agency mode contract, then there would be a similar adjustment to the MOE for those increases.
I'm the only one representing rural areas at the table, and most rural areas are paying really low wages, even through collective bargaining. And counties are screaming at the 35%. I don't know what this will do. I can't imagine that the rural counties, you know, whether we're talking 34 or 44, are supportive of this. I mean, I just can't imagine that they haven't been screaming about 65%. I don't know how they're going to do it, really.
Debbie has a clear. We're glad you all are here.
So one of the things that happened with creation of the 1617 MOE that continues through this MOE is a couple of options for the counties as a part of their bargaining process. One is called a wage supplement, where a county will bargain to have an amount that basically sits on top of their wage, their paid wage. So, well, I shouldn't say it that way. On top of their wage. So let's say they're paying a minimum wage of $13 an hour right now, and they, through bargaining, add a wage supplement of 50 cents. So their actual paid wage is $13.50. But a part of that is what's called a wage supplement. That 50 cents, the county pays for that increase of 50 cents once. They pay for it at the time they initiate it. So if I start it now, when the wage is 13 and it goes to $13.50, when minimum wage increases and goes to $14 an hour, that 50 cents is going to go on top of that 14 and make it $14.50 as my paid wage, with no county increase to their MOE. They pay for it only one time. So that was a tool that was created as a part of the 1617 MOE to assist counties in that, hopefully in that bargaining process, to address some of their ability to do bargaining. There was also a 10% option where counties, when we had the state participation cap, as we still do until that goes away at $15 an hour, if they bargain something above the participation cap, they can bargain up to 10% over the participation cap over a 3-year period, a 10% increase over a 3-year period, and the state will participate in that. So there was some things implemented as a part of that 1617 MOE that still continue now that are to assist the counties in being able to deal with some of those costs.
I have one same instinct.
Well, we have Nina.
Just really quick, I've
And then
been trying to
we
be really
does
quick for
anyone want
that.
to wrap up, or should we go directly into Kathy?
So just a question, this is very complicated for a lot of folks. It'd be really great if there were an infographic for those of us who have to hear and see. I don't know if you have anything like that. I'm just
Infographic.
asking. And like an infographic, just explaining,
Yeah.
that's all.
So, and to start, agree with what Debbie just said. The wage supplement and the 10% provision have been very effective in terms of counties utilizing those. Every county that's increased wages since the new 2017 MOE has used the wage supplement. It's a really good tool. We have some detailed documents on our website. I can share them as a follow-up to this group. I didn't kind of go into the wage and benefits because I was told for 5 minutes. But I certainly could have. So my one slide on it was not meant to omit anything. It was meant to just kind of point to the topic at hand. But definitely happy to share those resources as a follow-up to this group.
Can I just wrap up, like, so quickly? Like, one sentence?
Yeah.
Thanks.
Thanks, Justin, for all of that, and thanks, Debbie, for clarifying as well. I think the big takeaway I think we all want people to realize from this financing recommendation is we are not the group to figure this out.
Yeah.
But we are hoping to be the group to suggest that another group should figure this out. So the recommendation is really to put together a time-limited work group to come to the table, including counties, state, unions, consumers, providers, just making sure there's people at the table, but really to work this through in a pretty sophisticated way, and figure this out so that the funding really remains long-term. I think the big concern is that, that things happen quickly and what seemed okay today in 2 years looks bad, and so I think that's really our recommendation. Thanks.
Good. Thank you. Yeah, good job.
So I am asked to do a little overview of supporting people in accessing and directing IHSS services, which is a complicated topic. And I'm going to start by just talking a little bit about DRC's perspective on this, as well as provide some information about supported decision-making, which I think is a concept that has developed more fully in the intellectual and developmental disabilities work and less in other places, and is worth some discussion. I don't think we're going to get through this in 20 minutes. I think it is designed to be, here's a topic we should really be thoughtful about. So DRC, as the State Protection and Advocacy Agency, actually has two mandates. One is to protect the rights, including the autonomy rights of people with disabilities, including decision-making, and we're also responsible for working to prevent the abuse and neglect of people with disabilities. So in this topic, I think, those are sort of the two sides of the coin, right? How do you ensure that people have the autonomy to make decisions, and how do you ensure that people remain safe in the settings that they are living in? So I think we start from wanting to avoid assumptions and stereotypes about what people can do. I think it's very easy to say, if you have this disability label, it means you can't direct your services. I don't think that's true. And on the other hand, say people are incredibly diverse and have very diverse needs and capabilities, and that we always have to start from the individual and be thoughtful about what is that individual able to do, and what is that individual able to do with support. And so part of this discussion, and we've really been having part of the discussion throughout today, is how do we support people? There was a question about how do we ensure the person providing the service or the family members there for the assessment, because that can be useful. I think Nina said people really want their families around and involved, and those become some of the easier discussions, I think, when people have involved family. But some people don't, which is another level of complexity. And I'll just say on a personal note, I provide a lot of support to my mom who has dementia. And it is a journey to figure out how best to support people that change. It's not like every day is the same. Right. And it's, I have a terrific advantage because I've, been around her for a very long time, and I come to this work with a purpose of supporting people. But there are days that are harder than others, as we all know. So with that, I just want to introduce at least the topic of supported decision-making. I think we could spend a little time talking about that and how that might work in long-term care services. The first slide that Karen had, which is way back at the very beginning, sort of listed some other ways to do it, and I think adding to that list also just around care coordination and how we support people throughout a variety of complicated systems is another good one. So supported decision-making lets a person who's a senior person with a disability identify trusted advisors, which can be friends, family members, professionals, to serve as their supporter. These are not people who are authorized by a court, like would happen in a conservatorship or other kind of proceeding. It is not a substitute decision maker. So a substitute decision maker means somebody decides for you, but it is designed to be someone that you trust, who you can meet with, or who can meet with you with your IHSS provider or your social worker to help figure out what the possibilities are and what of those possibilities are going to work for you, to help you
hire the people that might be your care provider to help you manage your money if you're still able to do some of that. There is a very, the ACLU actually has a supported decision-making project, and there's a really nice set of materials on the ACLU website that I can send around. So there is also, as a piece of this, a realization that not everybody learns information in the same way, right? And so a piece of supported decision-making is how do we take complicated topics and make them easier to understand. I mean, I'm a lawyer by training, and that financing discussion, as you could tell, like I'm really confused. So presumably we don't have to explain that to many recipients, but take a similar thing that requires, sort of multiple things to think through, and you can see that, it's sort of the same process of helping people understand. So it can be different ways to get materials. So is it an alternate format for materials? Do people do better with audio information rather than visual information? Do people need more time to discuss options? A supported decision maker can say, here's 3 things that you might want to think about. Let's talk about those and break it down into some more concrete kind of real ways about what it might mean for someone. List of pros and cons of each of the decisions, helping the person think about that. Asking what's going to be most helpful to you and when you're thinking about it. The supported decision maker can go to any kind of appointment with the individual, whether that's the long-term care provider, whether that's a medical professional, as long as the individual indicates that they want that person to be there, because that's essentially consenting to whatever, HIPAA and other kind of rules that might be there. Opening a joint bank account to manage financial decisions, and I think that might be ones that people view as the most risky. Your relative walks into the bank with some unknown person. I think there's a variety of rules that banks have to exercise some caution, as opposed to it's a family member who walks in, or you do that early enough in the person's life that they clearly can give consent to that. But those are just ideas of, so it's who can the person be and how can that supported decision maker help that particular individual. I think one of the things that I'll send kind of around, there's a nice little chart that sort of shows what is a conservator, what is a supported decision maker, so that we have sort of a framework for thinking about that. I guess the last thing I'll say is I think it's worth considering whether within the long-term services system we should identify supported decision-making as a sort of as something in the statute that would allow that to happen. I think one of the things that happens is somebody shows up and is like, I'm the supported decision-maker, and people are like, what is that? And you can't be that, and all of those kinds of things. So changing that, there is a somewhat similar model. It's not called supported decision-making in the developmental disability system, where the State Council on Developmental Disabilities has the opportunity to help people identify who could help them make decisions. In that case, it's actually called an authorized representative, which I think is kind of a misnomer because they're not speaking for the person, they're helping that person make decisions and helping that person articulate the decisions. But it kind of provides a framework by a different name for what might that look like, and who within the community could help people identify if they didn't have a family member, other individuals that are volunteers, not paid, that could provide that same kind of assistance. So I think I'm going to stop there with that kind of very broad overview of supported decision making. There's lots of other options that Karen, and thank you for putting the presentation and slides together, that talk about, what is the role of a social worker who's doing, a really good job providing case management. When might that pose a conflict? When is that an appropriate role for a social worker to play? How do things like advance pay fit into any of this? How does a representative payee for Social Security benefits pay into that?
along with protective supervision and helping people access that as a service that can support and keep people safe in their own homes. I welcome other people's ideas. I think it's like a really interesting, complicated thing to figure out.
Patty, are you up, or is that?
Oh, I forgot to put it down, honey. Sorry.
That's okay. Then we have Peter and then.
Peter Mendoza, Consumer Representative. I really appreciate Catherine's comments. CRC and Catherine does a lot of great work in that area. I do want to just remind folks that it has to be the right person in that role. Recently, I was in a car accident, and there were a few days I was at home and I wasn't myself, so I knew I had to go see the doctor. I was having a hard time remembering names, and not big things, but little things I would normally remember. I was also very relaxed. My wife said something she knew would get me upset, and I said, okay, honey, whatever you want. Okay? So I went to the doctor, and I took my new personal assistant, her name's Sarah, and she has a nursing school background. So she and I worked to make sure that I could articulate to my doctor what I was feeling, and the fact that I was I was okay, but I was not myself. And there were a few things I couldn't remember, and my PCA did a great job of saying how I normally am versus how I was that day. On the other hand, there have been other cases where there's one relative who I love very much, but when they're in the doctor's setting with me, they don't behave well. They talk too much and they get angry if they feel the doctor's asking a stupid question. I don't bring them to appointments with social workers either when I have them, because they write emails and say how mad they are. And I go, you can't say that. Let me handle it. So it all depends on who the person is. And especially when you deal with major decisions or finances, it's really important that the person that they're utilizing is really trustworthy. And they may start out trustworthy, but stresses in their own lives may cause them to act differently. So these are all things we have to be aware of when we talk about supported decision making. In my case, I can make my own decisions. So, to be honest, part of me wants to see programs like in IHSS and other related programs. I don't want to have to see a worker as much, because frankly, I have to work, earn a living, and if I have to stop for a meeting, it's difficult for me. But I know it has to be done. Other people really need that, so we have to find the balance.
Seems like Donna and Karen, Ellen, maybe Ellen?
Ellen, Donna, and Karen.
I can wait.
Ellen, Donna, and Karen. You're running around in just in time for lunch.
Thank you. This is Ellen Schmeeding. I was just running down memory lane a little bit with Debbie, thinking about the supported individual provider mode, which goes back a long time. But the theory there was that the county staff received an extra allocation for providing those type of supports. And what I keep thinking about is the need for that broader care coordination that goes beyond IHSS and really looks at the whole person. But then I'm also thinking about the fact that that county administration costs would not increase if we added on the supported efforts through the IHSS allocation. So I'm thinking financially that could work well as an interim measure, because we just don't have a means right now to do full care coordination for the IHSS recipients or consumers.
Thank you so much this is Donna Benton. Thank you so much for that topic. one of the things is if we do have these trusted advisors, supported decision makers, I think it's really important that we do have regular reviews to make sure that there is a check-in to that people really want to continue with whoever the person they initially have, along with appropriate training for the supportive decision maker, which is, I'm just kind of echoing what Peter was saying, that we need those things. And then when we're looking at who can do this, look broadly and look within the universities and community colleges and areas where we can use other people and from maybe non-social work professions to help with this so that people can get information in the way that they want and also in the languages that they want to.
Karen Kiesler with CAPA. We tend to, in our registries, serve three different types of consumers. Consumers that have really low hours, and it's hard for them to find a provider. People who who are geographically remote, it's hard for them to get providers out there. And the third is consumers that really have a difficult time with the employment responsibilities. And this conversation makes me think of a situation, I think, Ellen, maybe 2 or 3 years ago, the San Diego Public Authority and county got this black eye through Facebook, and consumers said that a female IHSS consumer committed suicide because the public authority did not provide a worker to her when she needed it. Ellen may remember that was a situation with a consumer that had multiple needs, and it was not the fault of the public authority. Also, we had the situation about a year ago with a consumer in San Mateo who contacted literally everybody, I mean the Board of Supervisors, her legislators, lots of people saying, my public authority is not getting me a provider. They had provided 75 over a month, and the turnover and the dynamic between this female consumer and her workers made it just really difficult for a provider-consumer relationship to gel. This is an area where public authority staff partnering with counties and lots of other organizations, we need not just something that is the supported, directed, but we need more training that is going to cross where we know each other and what the other agencies are and where to really refer somebody, that it's not a public authority registry issue, it's not this, it's not that. So I'll stop right there. That's my recommendation.
This is Claire from Justice and Aging. I just want to mention to Ellen's point, I'm always hesitant to bring up anything San Francisco does just because I know people like roll their eyes a little and are like, well, they have all that money. But I think one of the things San Francisco has really worked to do is create a spectrum of care all the way from like on the far end to be complete independent provider mode, like you're doing your thing, you're the employer, all the way they do offer contract mode, which I know comes with its own financial challenges. But there is stuff in the middle, and it sounds they have what they call IP Plus, and it sounds a little bit like what San Diego was doing, although I don't know enough. But I think that's an example of a model where it's always voluntary. You can step up and you can step down because, you know, one of the things they've recognized is sometimes people might need full contract mode, like coming out of the hospital. They're just too fragile to be managing their own care, but they don't need that forever. Maybe they need that for 3 or 6 months, and then they step back down to hiring their own provider, doing all their employment pieces, doing all their own decision making. So I think that's the other thing that right now it's partially a money thing, but it's also partially thinking in a different mode from how we sort of set everything up.
Anybody else have comments? Anyone on the phone? What? Great. We have our county representative here.
Hello, this is Maya. I was accidentally on mute. Can you hear me now?
Sure. Why don't you go, Maya, and then we'll do one other comment.
Yeah, thank you. So I just wanted to reiterate what Karen was saying, and also Claire, that yes, San Francisco does have a great model, and I wouldn't just let money get in the way of it, because I think we do have to think creatively about the contract mode. Karen's, we do have consumers like the one that Karen was describing, where it just doesn't work to have an independent provider. And we used Homebridge in San Francisco, the contractor, for a while under the Coordinated Care Initiative. And it really helps with, it's not a large number, but with our consumers that were just not successful in the independent provider mode. I'm thinking in particular of people with, behavioral health issues, and they just can't hold on to the provider, that interaction doesn't work. So I really want to encourage us to think about how we build that possibility into the IHSS program more widely, and be creative about that. Thank you.
Hello, Paul Dunaway, representing the counties again. I first just want to echo what Peter said.
Can you just hold your mic a little bit closer?
Echoing what Peter said, I just wanted to comment that it really does need to be the right person. And then take an opportunity just to recognize the CWDA recommendations, and something that's closely correlated is the IHSS Minors program, and something that speaks to is collaborative decision making. And hearkening back to my child welfare days, team decision making. If the way of the future is really looking at bringing a team of people to make informed decisions about individuals, maybe that's another way to get at this issue.
So, any other comments? I think I'll just summarize by saying, really the beginning of an interesting discussion. I, like everyone else, don't think there's one solution of how we provide effective services to people and how we support people in getting the services they need. So I think all of the ideas are really worthy of consideration, and having kind of that, I'll just call it a menu of different ways people can be served. And I do want to just loop back to, there was a reference to the need for training, and I think training is sort of a long-term care services multifaceted. I mean, if you're going to have a supported decision maker, for example, it's really important to train everyone sort of what is that person's role. So the supported decision maker understands what their role is, what medical professionals understand that role to be, because I think a very common default can be that people rely on the person who is the most verbal. So in my relationship with my mom, somebody will ask her a question, and then, it takes her a while to process information. They'll turn to me and what do you think? And I'm like, let's hear what she has to say. But, visits are short, and so it's very hard to allow the time for that to happen. So just lots of good work, I think, to do, and worthy of a much longer discussion about how we provide that array of services to people.
And Catherine, not to jump ahead, can you point us to where these issues are talked about in the report? C24. Thank you. Thank you. Thank you. Okay. We do want to wrap up this issue, and since Christina is not able, I would like to pass it back to our openers, Brandy and Karen, who seem ready, so that's good.
Completely her.
To Brandy. Only Brandy, Karen says.
So thanks to everyone for a really great discussion, and thanks to the work group that sort of put this part of the agenda together. I claim no credit. I was very unhelpful to the group last week as I was traveling. So thanks to everyone that stepped in. I think overall I heard a couple of issues that are really cross-cutting across all of the recommendations. The issue of services under the new definition of what is a home, shelters and homelessness, broader issues of care coordination, and as Catherine mentioned, training sort of across all different spectrums of the IHSS program. For emergency backup system, sort of just recapping, we will make sure that recommendations that have come in, again, on sort of this timing that we are using, are being put into the document. I think the suggestion that Craig made that really resonated around sort of tiering the level of need, starting with the most vulnerable. One question that I did have in the recap is to Lydia's point about exploring what regulations could be lifted in cases of emergency. Is that potentially something that we could pivot to the research subcommittee for exploration? or is that?
They don't do them, no.
legal,
Okay.
but I'll think about where it could be pivoted.
Yeah, I just want to put a pin in that because it seemed like a pretty definite, like, research request. So I think the takeaway is there was a lot of good discussion around, sort of those cross-cutting issues around homelessness and broader care coordination and emergency backup system. So we will take that back and integrate those into the document. In terms of assessments, around the recommendation, just ensuring that we are incorporating the role of family caregivers in the assessment and making sure that we are utilizing existing care teams and the abilities of the managed care organizations. And then on our final topic, I think Catherine did a pretty good job of summarizing us here. I heard Maya's request to have this group or some iteration of this group really explore contract mode in IHSS for those consumers that are unable to self-direct, and just ensuring that there is adequate training and sort of oversight for people that are performing supportive decision-making.
Wow, great job.
Yeah.
Any comments? Yes, applause for Randy's amazing summary the past 2.5 hours. If there are no questions or comments on that summary, we will pivot to public comment on IHSS, or what would
This is very unreadable. Would you like me to type this up and send it to you?
And then we could even potentially extend our lunch break or even come back a little bit earlier to jump onto the report. Everybody okay if we go to IHSS public comment?
Yes.
Okay. So let's start in the room, and meanwhile, I'll give the heads up to our wonderful tech team to get the on the phone. How many folks are on the phone total? Do you have a?
Yeah. About 46 of 11 are platform, 9 are
Okay, great. So that gives us a universe. Okay. Good morning.
Did we not get all?
We can't hear you fully. Can you, or I'll swap mics with you if that one.
River College?
Oh, yeah.
Got it?
Yeah.
Okay. All right. First, I want to say thank you for all the really apparent hard work and things that you've been doing in the past couple of months. I haven't been able to be at all the meetings, and I went through a period of angst because I couldn't see the workforce piece coming into the conversation, and it really is clear now that it's here, and I'm very happy for that. And I just wanted to, as my comment, point out an intersection between the caseload issues for social workers and the case management. All of these pieces are coming together, and from an educator's perspective, it's really very clear we're never going to change the caseload issue through the academic world. We cannot produce enough social workers to keep up with population aging. And I want to really suggest we start thinking about how we can create these scaffolding positions through assistant-type roles. And there is and that also intersects with this conversation that I just heard about supportive decision-making processes. I really, having done hands-on geriatric care and care team management, understand that it's not just people with disabilities who need this kind of support. And clients go in and out of being completely capable of making those decisions on their own. And when caseworkers are overloaded, there's a tendency not to have enough time to give them the information, and they are not properly assessed. So the 4 areas that intersect are a role called social services designee that exists within the RCFE system, a type of training for people who, in an RCFE where they have less than 55 beds, they don't have to have a social worker on staff. And so individual people who work in the facility have to learn how to be an advocate and help. So that's a role that's already established that could have a formalized training component set up to scaffold into this. Service coordinator is another position that's formal that would be very helpful in this case because they would be people who understand what the programs and services are out in the field, and there's a training component already that exists for that. And then, of course, that also intersects with information and referral services. But to me, it seems like we need to create a position and establish the training for it here in our own state that's going to prepare people to be case managers who initially, because it's really difficult to become a case manager in the field of aging because the formal professional organizations require you to complete a test and certification that is not just for aging. So you have to be qualified across all populations, and that makes it really difficult. So just putting all that out there for the hopper, and one last comment. Emergency response, because I work with activity leader course approval, I just want to put out there that sometimes the person who is really in a position to make a difference in that emergency moment is the person who's staging people for support and help, and it's an activity leader who has no professional license, and it's really difficult for them to navigate that system. It's not like an RCFE where the administrator is responsible for making sure everybody's trained and knows what to do. It's caregivers and entry-level people really need some formalized training requirements there and access.
Thank you. Thank you. Other public comments in the room? How about on the phone? Lisa, go ahead.
Yeah, hi everybody. This is Lisa Codmer. I'm a consultant, and I've spent probably 20 years working on improving healthcare systems for low-income seniors, people with disabilities. And these days, I find myself working on homelessness all the time. Almost everything I'm doing is connected to homelessness. It seems like I've arrived here like a lot of us have because of the homelessness crisis. So I just want to strongly support the comments that Lydia and Claire and others made about how a personal care attendant can play a role in not only helping someone emerge from homelessness, but also the role that a personal care attendant can play in preventing people from falling into homelessness. And that might be through exploring other models like we've discussed, like for people who really, truly can't self-direct. I'm a huge advocate of self-direction, but we know some people cannot self-direct. People with Alzheimer's and other dementias, people with behavioral health disabilities. So anything that we can do to be creative and support people remaining in the community and avoiding institutionalization through the provision of personal care attendant services, I am strongly in favor of, and happy to partner with any of you on any of this as we move forward. Thank you.
Other comments on the phone?
Hello, can you hear me?
Yes.
Okay, I am a recipient of in-home supportive services, and I was really interested in the collaborative decision-making that was proposed by someone earlier, and training in the IHSS regulations. All providers are signed on to Elder and Dependent Adult Civil Protection Act, that they are mandated reporters.
True.
And I don't think that many recipients know about that. And maybe even the providers don't, because I don't know if you address that in orientation. You know, I think there should be a provision made for the recipient to be able to report any problems, because sometimes people are afraid of their caregiver and afraid of losing services if they say anything. And so the social worker that comes out and does the annual interview should also look for any signs of that type of problem. It's a very serious issue. and hopefully there'll be some way to initiate proper training also for the recipient to know that they can not only call Adult Protective Services, which puts them at risk for institutionalization, but, to have a way to really work it out with IHSS and not have to go that far to go to the Adult Protective Services.
Thank you.
You're welcome.
Any other comments in the room or on the phone from the public? Okay, then. I would like to do an agenda check with the group. It is about 12:15. We were planning to break at 12:30. We can break now. Lunch is here, and then stick with our return at 1 o'clock to have a little longer break for email and food, or should we start? Does that work for people just to stick with the 1 o'clock? A couple other technical details just in terms of we will be discussing the draft report. The good news is the draft report, as of moments ago, was just posted on the agency website, so people calling in and listening. So thank you to Ellen and all the elves behind the scenes who are making magic happen this morning. The team has also just sent over a few slides to help guide our conversation. Those are not posted because they're just hot off the press. We'll be beaming them, so if you're on Zoom or in the room, you will see them. But if you are on your phone, you will not have them. We can, let's see, for the subcommittee members, we can try to email Maya and Christina and Dr. Avalos to make sure they have them as well. But I don't think we've yet come up with a good solution. We'll try by 1 o'clock for the public to see the slides. They are reflective of the document that is publicly posted. They are meant as a discussion facilitation tool. I don't believe there's not new information in them. But if you can shift to Zoom, that would be the best choice for the afternoon. If you are really needing to see these slides, I think email Engage, and we'll try to email them to you. But the best thing would be to go to Zoom, and again, you can follow along with the document. Any other updates before any lunch instructions for I guess we can do that in just a second, but anything else for the meeting logistics before we break and then come back to tackle the draft report? Okay, so lunch and
Okay, so we have a variety of boxed lunches and drinks, so help yourselves, provided by our various generous foundations. And there are 2 gluten-free lunches, so.
2 what?
Gluten-free.
Oh, God.
So run.
Go first.
So you've dropped out
Yes,
the stuff that says
Thank you. We'll talk to you again at 1.
priorities and consensus.
Comments?
Please do.
You guys did a great job.
The comments that were.
I'll eat it. Are you saying the recommendations were dropped out or the comments were dropped out?
tracing our steps. We've had hundreds, maybe we're bumping up to 1,000 stakeholder comments and recommendations. We've taken public comment at all of our meetings, the SAC meetings, as well as so many community roundtables and forums. We adopted a framework. That's the beautiful AARP graphic that we shared. Next. Oh. Okay, just for effect. Initial draft. All right, so we're about end of the middle here. We adopted a framework that included an overarching circle of cross-cutting issues, and it included 3 buckets, pathways to care, access to care, and LTSS affordability. Those then became the outline for the LTC report. Subcommittee members self-identified as writing team captains and recruited interested parties to join them. And those teams reviewed every single recommendation. Thank you, Carrie, and the Dropbox. They were assigned to one of the 4 teams, and each one was considered. Each of the 4 teams then produced a draft as of Friday, January 24th. And what you have today in front of you is a consolidated initial draft report. And that's what we're going to be talking about. So this initial report, we never talked about how we wanted it to look, but today it's 27 pages at 12-point font. We'd like to get that up to 14-point font for accessibility standards. We now have 5 priorities called out. We might have 4, we might have 6, depending on discussions. And today we have 42 recommendations. Some are very dense. It could be argued that some of the recommendations could be broken into multiple recommendations, but the way it's organized today, we have 42 recommendations. Still to come, we would like this to look nice when it's presented to the SAC, but all of the content has to be agreed to and finalized. We want to include some graphic or infographics, photos of Californians, and quotes that came in through the public comment process. Oh, thank you. I'm looking at my screen.
I know, I was going to help you out.
This is a very dense report as it reads, and it doesn't come off as person-centered, but that's our goal. So we want to make sure that the report is a person-centered framework, and there are ways to do that. It doesn't include a table of contents or page numbers. If you're into that. And there will be an appendix. We all agreed that all of the recommendations will be appendixed so that the public can see everything that was collected. And all of your names are not included. So every member of the work group will be included as a contributor. What this initial first draft is and isn't. It is focused squarely on LTSS. Just a reminder that that is our charge. It's a start, the beginning of our process. It's not the end. It's our best attempt to date to catalog. It's a cataloging, and that's important today, as you heard from Kim. What is missing? What did we omit? It's an attempt to organize the material and the start of prioritizing. The report is high level, so we really tried to keep focused on the what and not the how. And it's intended for multiple audiences. In reviewing the executive order, the report is due to the governor, as the executive order states. We're delivering it to, so that is our final audience, also the Stakeholder Advisory Committee, the other work groups that have been formed in our meeting, and of course the public. What this draft is not, it is not the master plan for aging, so you will not see everything in this. There's a lot of other work going on concurrently that will get rolled up. It's not yet a consensus document. We wanted to be, we've not voted or agreed to most of what's in here. It is in our final report. That's not due until March 2nd. It hasn't been fully vetted, so there are recommendations in here
that surfaced, but didn't go through a review process, weren't part of a deep dive. We wanted to honor those, but you may see things that you haven't heard yet. And it's not granular. So we really tried to stay out of the weeds with this document. Here's what we hope for. We hope that the report is accurate. That's very important. That it's actionable. That's why we stayed in the how instead of the, or the what instead of the how. That we wanted to avoid language that's more lofty and principled and language that's actionable. We want this to be ambitious, bold, and certainly equitable. And I think there's room for this to be provocative. I think we've not yet decided as a subcommittee, but we don't only want to put things in here that everybody's okay with. And we also don't, so we want to provoke thought and discussion and further work through this document. Today in our session, we want to figure out what's missing, what's misplaced or belongs elsewhere, given that there are other work groups and committees that are meeting. In particular, an area that we saw a lot of crossover was around healthy aging and some of the clinical issues that are more medical. They're absolutely related to LTSS, and we don't yet know what's going to show up in that group, so there's a tendency to want to make sure it shows up here. So that's a question. But there are other things that we didn't know if they belong here. What are you unable to support? Is there something in here that you just can't sign off on, or your organization, or you don't believe in? What can you enthusiastically support? Those are things that we can quickly dispense with. We outlined 5 priorities that came up over and over in each of those settings. The group may decide they're the wrong priorities, that there are more priorities, that there are fewer, and is equity captured? This was another issue we struggled with because we sort of toggled between naming and calling out communities and groups, and then using broad, sweeping language that felt very vague. But then when we found that we would identify an individual, a community, it implied that also didn't affect other communities. So then we felt we had to name every community that it could possibly impact. So we struggled a lot with how to include equity in a meaningful way, and to include all of the groups. The groups identified by the equity work group, but other groups such as rural or live alone or the disability community.
That's not a group. Rural is not a group.
Or subpopulation.
It's like 80% of the state.
Yes. Communities and populations. And then we don't have a process yet to achieve consensus in how do we include unresolved big issues, many which are controversial. And our next steps, we have a public webinar this Thursday to walk through the initial draft report. We'll be asking for all of your input, comments, feedback by noon this Wednesday. This does not have to be, we're asking that all of those comments be sent to Carrie. Your best effort by Wednesday.
Engage email, then it'll go to
So we decided that instead of to my email, it'll go to the Engage Age email, and then it'll be forwarded to me too.
Great. So for those on the line and listening in, anyone who has comments on this document, whether they're on the subcommittee or the public, can send comments by this Wednesday at noon to the Engage website. And they will all be collected, and we'll try our best to turn them around by Thursday's webinar.
And please put the words LTSS report in the subject line of your comment. LTSS report.
Please put LTSS report in the subject line if you're sending comments related to this initial draft report.
For the public or for us?
Everybody.
Us and the public.
We want to make sure we've already started getting some comments, and we're worried that we'll miss something, and so we want to make sure all of the comments go to one place so that we can be confident that they've all been received. We'll then finalize the report. Well, on February 19th, this subcommittee will meet again, and we'll have, it won't be an initial, it won't be our initial draft anymore. It'll be much better on February 19th, and thank you for allowing us the time. It's really going to work in our favor. Then we will finalize a report to share in advance with the SAC group, and we have a webinar scheduled for February 26th so that the March 2nd meeting can be most productive. We will walk them through the final draft, and they may have thoughts and changes that we need to incorporate by March 2nd. And then on March 10th, there is a public webinar to unveil the report.
Question. Yes. So I know the February 19 meeting is a meeting in Sacramento with the committee at Department of Aging. What about the March meeting?
The March 2nd meeting?
Yeah.
That is a meeting
Who
of
is
the...
no, you have the Stakeholder Advisory Committee. So is the whole committee supposed to be in attendance with that at the March 2nd meeting?
March 2nd is the Stakeholder Advisory Committee meeting, and we have a webinar March 10th to review feedback.
Well, who's presenting then, who's presenting the report to the Stakeholder Advisory Committee? Not
We haven't talked about that yet.
Okay, because I didn't know if that meant the whole committee was to be present or just representatives like Sarah and Susan. Okay, okay.
And we're fortunate a number of members of this subcommittee are on the SAC, so we can figure that out.
Yeah, you're right.
So for our process, our suggested process going forward, we're at a critical decision point in terms of, do we go left? We're at a fork in the road. Do we produce a report that's all consensus? Do we produce a report that's prioritized? Do we produce a report that includes things that are half developed? We'd like to retask the team captains with taking feedback after the webinar and drilling down again with the group that started this work and really owning their piece and getting it right. We'd like this subcommittee to provide clear guidance to the teams in terms of direction on consensus, prioritization, vetting. Does a recommendation make it in if it hasn't been vetted? Should it be included or should it go elsewhere? Formatting, which we've gotten, I think we're close to. We want to establish a mechanism for public input, and I think we just heard from the Engage, that public comments can come into the Engage website. Today we want to figure out our goal for the webinar at the end of this week and get to the vision, Patty, as you asked, for the February 26th webinar and the March 2nd meeting. And then we will need some technical assistance in finalizing this document and the graphics and the design, and we're not sure how that piece will work.
It'll come together somehow.
So we'll pause there. That was a lot of information. Are there questions about those, any of the slides or anything that was discussed before we jump into the document?
Yeah, this is Maya. Can you hear me?
Yes, hi Maya.
Hi. Just a question. So you said you wanted feedback by noon on Wednesday. What if that's not possible? I mean, I assume there's plenty of time for feedback afterwards as well. I mean, for example, I'm just really jammed, so I'm not going to be able to do much before Wednesday.
Yes, that's Maya. That's absolutely all right. We want to hear if somebody has a burning issue that we need to correct before the January 30th webinar. We'd like to hear that, but there will be other opportunities for comment.
Okay, thank you.
Hi, this is Ellen Schmeeding. The one question I have is how to put together an executive summary to go with it so that we have something that's a little bit abbreviated, well, quite a bit abbreviated, that we know will get good attention. So
Probably be the only thing that's read.
Yeah. Well, I don't know that. I think a lot of people love the detail. They love input, and they're going to read the whole thing. But something with links back to the larger report and recommendations, and those are technical aspects. But I just think it's a tremendous first draft. I was really impressed. I was half asleep when I read it, but I was just cheering all day.
This is Peter Mendoza, Consumer Representative. I agree that a executive summary would be helpful. I also want to really convey my appreciation for all of the work that everyone did till 1:30 in the morning and beyond to put this together. My question is for the public who may want to comment. Is there a copy of this document on the Engage website so that folks can?
Just went up at noon.
Okay. Okay. Thank you.
And then again, emails at the Engage. If people can't put LTSS report, that just helps us sort it quicker. But any email to the Engage and of course public comment today, both in time to have, if it's anything we get before Wednesday, we can try to incorporate in the webinar on Thursday. But that's not, things that come in after, there's still a chance.
Oh, yeah.
I'm going to do a follow-up. Are those instructions on the website too?
No, not yet.
It might be helpful to get those instructions on the website in a way that really kind of points it out to folks.
Marty has a question?
Marty Moto, City Can. Yeah, good pulling all this together, so thank you for all of that. So the overview that you gave was actually very useful in trying to explain what this is and isn't. And is that going to be posted anywhere? Because I'm just thinking for the public to see this cold,
You're right.
they're going to ask all the questions that you just answered.
Yep, yeah, that's a good.
And so having that up there was very, like, what this is, what this isn't. This initial draft headline. That was very useful, actually. I thought.
Okay. We'll
And also your cell phone number and.
For the writing party, you want?
Okay. Any other comments on that? Now we're going to, Sarah is going to walk us through the report, high level.
High level.
Walk us through.
Okay. So what we'll do is we'll walk through it, and then at the end of each section, we'll do just really, really brief clarifying questions. But then we want to open it up to a chunk of the time now, then to start getting into the heart of the discussion of what are the big ideas that we might be able to find consensus on, what are the big concerns, and what's omitted that needs to be addressed here. And I would also add to that, just really, really critical, what's inaccurate, because that concerns me the most. I'm really, really pleased and appreciative of the county's presentation today, because that recommendation about fiscal alignment and the fiscal incentives about IHSS payment doesn't apply as much anymore. So I feel like that's one example of an area that really is lacking the accuracy that it would need. So that's just one example. And Susan has one more thing.
A bullet I forgot to include is, as a rule of thumb, we called it one and done. So we tried to find a home for every recommendation, but not have the recommendation show up in multiple places. So we would encourage you not to argue for populating your recommendation in every bucket unless there's a compelling case for that, because the report would quadruple in size.
Okay, great. So again, right now what I'll do is I'll briefly walk through it. The first page is just a high-level summary. I wouldn't call it an executive summary of the report. It's just an opening introduction, and it outlines the goals of the subcommittee. It incorporates some of the language and the writing of the cross-cutting work group about vision and equity. Thank you, Ellen, for that. And then on the first priority A on page 3, I have since put page numbers on my report. It helps a little bit. Maybe next version will have page numbers. Priority A focuses on issues about statewide leadership. This is in the cross-cutting work group area, but really pertains to state leadership, starting at the gubernatorial level, looking at the structure of aging and disability programs at the state level, and then also exploring the feasibility of integrating aging and adult services at the local level. So those are the three main areas that were captured in that section. So again, thank you to Ellen for your efforts to lead that work group. I will pause there because I'm going to pause between every work group. Any comments, Ellen, that you wanted to just clarification before we get into content stuff?
I just wonder what happened to the data recommendation.
Yeah, that went into data, RECO went into access because we felt like the theme was leadership, and even though data is cross-cutting, it aligned very well with the data recommendation in the access work group, starting with the information, the local information inventory, going to the kind of a more integrated data system after that. So we can revisit that as well. So that's something that we can talk about that. Other questions about that bucket? If there's no clarifying questions, again, save your comments about concerns or omissions. We'll discuss that. Karen.
Just to clarify, so if you, the CWDA paper that dealt with a bunch of different things that crossed into information assistance, IHSS, is that all then housed in that paragraph?
No, I don't think so. That is housed as a structural recommendation under recommendation A3.
Okay.
My understanding is that it also gets incorporated into the pathways discussion under INA. That's my recollection. It could be that it's missing, and so we need to revisit, but that's something to look for. Because there were many letters submitted, there were issues that crossed multiple buckets.
Right.
And we tried hard to make sure that we captured the multiple buckets. We didn't just put one letter into one bucket always, but that doesn't mean it got captured accurately. So, something to look for. Okay. Any other questions on that? Leah,
Just one other quick thing.
So we also reviewed some what I'll call position papers or recommendations that had multiple topics.
Yeah.
So those we really struggled to kind of tease out, like Sarah just said, and put into the various aligned buckets. So if you notice anything there that you think's in the wrong bucket, we can certainly move it.
Yeah. Great.
This is Maya.
Yeah.
Can I get in the queue?
Of course.
So I haven't had a chance to read this report. Thank you again for all this tremendous work. But one thing I don't see in here is sort of the overall vision that we want to convey for LTSS, or any vision.
Yeah. Well, that's a good point. Maya, on page 3, there is the statement about vision, but I agree with you in terms of messaging for the report. I think that your read, though, is good because it shows that I think we need a stronger messaging throughout the document, and that statement is made there, but I think it's an important point that we need to build it out. So I will note that.
Yeah.
So,
Thank you.
okay.
Good.
Next, this was probably an easy bucket. Okay, bye. See you all later.
That was going to be my question, is it appropriate to stop for a minute and get feedback, or no?
Well, so this is the thing. We had initially said we wanted to do a high-level walkthrough just to summarize. And then I think what we need to do after we do the high-level walkthrough is then open it up to the bigger things of omissions, concerns, and the big areas, okay? Just that way we don't go down one rabbit hole and then forget to go through the rest of the report. So is that good with everyone?
Yes.
Okay, so moving to Pathways to Care, this is the group. Thank you to Maya Altman, who spent so long putting all of this together, and she wrote, I think, a term paper on it, which is amazing and wonderful, and it was really difficult to have to streamline it because it was all really, really good stuff. So I would flag this section as one that will need additional meat on the bones potentially, not too long, but kind of toggling that line that Susan was talking about wanting to be actionable and clear, but not getting too far into the weeds. So that's just a little bit of a marker on that one. But this bucket, Pathways to Care, addresses how people get their services and support. So it's not the infrastructure, it's the pathways. And this applies to the information and assistance platform. We report the recommendations around standardized screening and assessment. Care transitions from particularly institutional settings back to the community. Vision for integrated and coordinated service delivery system. I would say that the section on the issues impacting integration under the CalAIM proposal, there's a big struggle about how specific and in the weeds to get related to CalAIM, since this report isn't going to have an impact necessarily on CalAIM in particular, but it could have an impact on the broader policy related to integration. So again, trying to work through that level of detail. And then it goes, after the issues of integration, it goes into the issue of data collection and evaluation. Oh, that's related to integration, so that's not the other component of data.
Please refer to the pages that you're on.
Sure, this is page 8, B7 and B8 are again about integrated service delivery, the data collection. Recommendation B8 addresses the integration at the Medicare level. So this is for individuals eligible only for Medicare, not the dual eligibles, but this was something discussed at our meeting a few weeks back. And then the recommendation looking at state level leadership and planning and implementation council establishment on integrated service delivery, B9, and then recommendation B10 focuses on advancing innovations in integrated service delivery and looking at development of new models of care to help a broader population access integrated services. Those are the summary of the recommendations on pathways to care. Again, buckets of information assistance, screening and assessment, but not IHSS assessment, integration, and yeah, I think that's all the issues under that. So questions, just to clarify, and care transitions. Questions to clarify on that bucket. Nina.
Something a little lost.
Okay.
So I heard you
Understandable.
say two things. One, on the data piece, which I know was under Medi-Cal. Oh, yeah, I should touch the microphone. Apologies. Nina Weiler, Harwell, ARP. So I'm trying to figure out exactly where we are. So there was a data recommendation under Medi-Cal managed care. And then I thought I heard you say something about LTSS for other additional populations, i.e. those who don't qualify. So I'm not sure which recommendation.
Okay, I will clarify. Recommendation B7 gets to data collection and evaluation of integrated care delivery. So it's looking at evaluating what is now the CCI and learning lessons learned from that and applying it to the new integrated service delivery system that's being developed through CalAIM. So that's what that report, that recommendation is on. Not to be confused with the general data recommendations that follow in the access bucket on just general data issues. Okay, and then you are right, then following that, there are recommendations about integration and models in the Medicare side of the service delivery system, and then innovations after that on B10 on integrated service delivery. Okay? Again, all of this might need to be reordered, but we will take those comments after we do the walkthrough.
Okay.
Did you have any clarification?
I'm saying comments if I can. So the logic model here is we're talking about the pathway to care that begins with your Medicaid health plan, the pathway to care that begins with your Medicare health plan, the pathway to care that begins with your. This is at the pathway section, right?
Right, correct. So in general, pathways, integration is a pathway to care. So there's several different kinds of integration. There's integration across Medicare and Medi-Cal. There's integration at the Medicare level. And then there's building off current models that integrate services for dual eligibles, but expanding them to a broader population. So what I'm hearing is confusion about how this is categorized as a pathway, and I think this is...
opposed to a system of delivery, yeah.
Right.
Which it could be either, but...
Yes.
Which, yeah. Okay.
because it's the thinking was that integration is a pathway, because you have all your services integrated, and that's how you get and access your services. So that's the pathway.
Plain language.
Yeah. Totally agree. And that was one of the biggest challenges, is the plain language with that word integration. Is really, it gets so wonky fast.
So my question's not on the content of, or the placement of the recommendation. It's a process question about how to deal with objections. There are some of us who feel very strongly that we should not be spending time talking about integrating IHSS into managed care at all, and that was a commitment that was made up front at the beginning of this process. So at least that was a commitment that some of us felt that was made at the beginning of this process, that was a CalAIM discussion and not something that was going to be here. So I don't want to debate it so much as to understand where and how to go about killing it.
I appreciate it. Karen, this is really, really important, and this is a conversation that we absolutely need to be having. So what we can do is, I'm making a parking lot of the concerns, and that will be one that we start with. How's that?
Tollway zone.
Yeah.
Okay. Tollway zone, yeah. So,
And Sarah, I want to just add one other quick processing, that we do want help later on getting the document, once there is more consensus around the final, into plain language.
Yes.
So that's a really
100%. Plain language is good. Yes, Ellen.
I was just going to say, I hear your concerns, Karen. I must have missed the meeting where some statement was made about not including IHSS.
I don't remember
Well,
that
and I
either.
think that we should table that whole discussion for our concerns discussion, because I think that these are all important perspectives that we all might have different perspectives on. So we want to have good discussion on it.
Good.
So that's on the parking lot list. Any other questions about pathways, just to help clarify for folks? Okay. Next. After pathways, we get into Lydia's bucket. Thank you very, very much, Lydia.
Sarah?
Sorry, yes, Maya, hi.
I'm sorry. Somehow I keep getting muted accidentally. But I just wanted to make one point of clarification on the pathway section.
Sure.
We didn't talk at all about integration at the clinical level. And I think that was purposeful, because that gets into the point that was made earlier about what goes here as opposed to what goes in health and well-being. In that, at the very clinical, we're talking about systems here, but at the clinical level, you go to the doctor, and how do you get access to LTSS services? That we don't really discuss.
That's an important point.
Yes.
Great
That's
point.
an important point to keep in mind, that's missing, and maybe we should say that up front, that that's missing and that's purposeful. Because that's a whole nother, integration at the point of care at the service delivery level is another whole topic.
Yes, thank you. And that gets to Kim's question about the pathways, of how it's a pathway. And I think that we need to give some consideration, as you said, about whether we want to call out clinical level. And that could start to get us into a little bit of the quasi-health territory, which, so just good topics to think about. Okay, so now we move, if we're good, if everybody's okay, we're going to move to access to care. And again, right now, what we want to make sure is people understand what's in here and clarify questions. And then once we wrap this up, we'll go into the bigger concerns, omissions, and big ideas. Access to care, Lydia did an amazing job with her work group, just pulling together with 69 recommendations, but she then was able to give away a couple of recommendations to other groups, and she, I think, brought it down to 63. So, she's kind of a little bit of a slacker that way. But, so the access kind of covers a number of different areas. It starts by looking at the accessibility standards across sectors, and we really wanted to start off with this one. This was a recommendation a few people brought forth. Jeff Tom had it really built out, but we thought that it was really cross-cutting over all of access, about ensuring compliance with the ADA and enforcing, but also building out just general access across the service delivery system. And it can go anywhere from home and community-based services to institutional settings. So there's a statement made about that under recommendation C1. C2 then starts to get into this issue of defining a core LTSS mix by county, and stemming from that, developing a 10-year public-private infrastructure plan. Because you can outline a core service mix, which is helpful, but then how are you going to actually get there? So the idea is to have an infrastructure plan that follows. Lydia outlined a format for outlining the service delivery mix, and then following that is a number of all the recommendations that came in about immediate infrastructure needs to shore up our current system. So you'll see a lot of the needs in terms of strengthening the financing of certain programs and increasing access to different programs at the statewide level.
And those are recommendations C3 through C6?
No, that was recommendation right there, C2. So it lays out the core mix by county and recommendation for an infrastructure plan. But then it also calls out the investment of different, current investment. I think we need to distinguish these bullets a little bit, and I'm going to make a note on that. Because you'll see the third bullet down, third big bullet down, then segues into investing and stabilizing funding in the short term. These are more short-term investments. Yes, please.
I just wanted to highlight for our discussion after Sarah finishes, under C1, strengthen and enforce accessibility standards across sectors. The research committee, subcommittee that met Friday was very interested in access standards, but punted back to this group to help develop those. So keep that in mind as we continue the work.
Okay. So moving right along, we then move into, we had a good discussion a few meetings ago on, while the state is moving to a more, a delivery system built on a managed care framework, we also recognize that we are a far way away from that, and we have some really critical home and community-based service waivers that provide services to older adults and people with disabilities, and there were a number of recommendations that came in about expanding access, really, really critical, expanding access to these programs, and easing the way in streamlining access to them as well, because right now they're hard to access for consumers and administratively complex. The next recommendation looks at supporting the working disabled population, and this gets into a lot of the fact that people with disabilities can face disincentives in obtaining employment because they lose access to public benefits. This is, again, one of these quasi-LTSS / Goal 4 areas, but it does pertain to LTSS because people lose access to their LTSS once they gain employment. So there's some recommendations, again, that might need some tweaking because we tried to consolidate, condense them a little bit, but appreciate your review on that. C5 looks at expanding access to equitable, accessible, and affordable Medi-Cal coverage. This was brought forward by Justice and Aging and a few other advocacy organizations. And again, one of these issues that really crosses over from LTSS to healthcare, but because Medi-Cal is a primary payer of LTSS, we felt that this was an important series of recommendations to include as it impacts access to the program. And then we get into expanding the Aging and Disability Resource Connection Program statewide, which again, this was a Pathways program because this is how people access information, but the statewide expansion of it is more of an infrastructure issue. So again, these are up for discussion about placement. Okay, the next, we're on turning to page 14, number C7. This calls out, this is a whole section that, or this recommendation focuses on looking at equity for underserved populations in the LTSS service delivery system. And Lydia, I don't know if you wanted to comment on that because I know a lot of consideration was given to how to present this one, but we can discuss that in our broader discussion if people have questions. And then the next recommendation, C8, looks at improving emergency preparedness and response in the overall LTSS system. A lot of recommendations coming in to that extent. And then in the next section, recommendation C9, there's a number of recommendations. This is where we got into a lot of the really critical issues around quality and choice in 24/7 residential care settings. Really excellent job. I think it was Ellen that summarized and condensed the recommendations. I think there's a lot. This is where this gets really hard because there's a lot not talked about here that it's hard to make this a brief, concise report without brushing over issues. So this is just something for the committee to consider about how it's presented and what we might want to do, either to strengthen or to call out issues, because there's no place right now at this point where where we give analysis to other perspectives and viewpoints. So it's just.
But they are at least called out.
They are called out, definitely called out where there is not a consensus and agreement. The next recommendation starts with the workforce issues on the bottom of page 16, recommendation C10. We had a good conversation with Nina and with Donna. There was a little confusion on what the recommendation was, so we have it clarified, and we're going to incorporate their Family Medical Leave Act recommendations and a few others into this recommendation. Again, supporting our family caregivers, along with the recommendation to strengthen the access to caregiver resource centers. The next recommendations get into expanding paid workforce supply and working conditions. So you'll see recommendation C11 and C12 looking the supply and education and training strategies under the workforce. The next recommendation gets into the full practice authority for nurse practitioners, and then followed by that, recommendation C14 is the issue of nurse delegation of authorized health maintenance tasks. These are two examples of, I would call them pretty controversial issues. So again, these might be ones we need to discuss further. Recommendation C15 is one looking at primary care and psychiatric residency positions in California. This is another one of these that I think kind of wavers on the line of maybe potentially going into the healthcare arena, and we have to talk about whether it goes here. Okay. And then another recommendation, C16, looking, this was a comment that we've heard about the needing for, there's a shortage of workers in many of the paraprofessional positions and needing to develop a category of paraprofessionals across a number of different areas. That was something that was discussed earlier today in public comment. So then we get into the IHSS program issues, and actually the section for IHSS, I think the microphone's sick of listening to me. Yeah, it's dead. Oh, thank you. IHSS begins at the very bottom of page 19. There's a dangler, but then you'll see that I want to just say the IHSS group, you guys did an incredible job. I cannot believe you managed to condense these recommendations in very succinctly, and it's very, very clear. So thank you. It was lovely. So thank you. So recommendation C18 on strengthening the IHSS workforce. C19, improving access through streamlined administration of the IHSS program. And again, you'll see in each of these, we really tried to have just a 1 to 2 sentence issue statement followed by the recommendations, and closely aligning the issue statement with what's in the recommendation. Under C20, it focuses on the public authority practices and training. C21 on page 23 looks at the stability and sustainability, and we have stability 2 times. Of IHSS financing. This is what happens late at night.
So we
minutes.
Really mean
Yeah.
Really mean
Really
Good
stable.
point.
Really stable. And we'll put a really stable in there. C22 gets into, we talked about this a little earlier today, equity and access to the IHSS program for traditionally underserved populations. Improving the coordination between IHSS and other LTSS providers is recommendation C23 on page 24. Recommendation 24 looks at increasing support for IHSS recipients through, this is the contract mode, and looking at, again, those people that might need a little assistance in managing their IHSS. And then C25 looks at simplifying administration of the programs for recipients. And then finally, what we discussed on today is improving emergency backup systems for IHSS. A lot of recommendations under that. Okay, I will pause there and wanted to take questions on Section C. Thank you again to Lydia and to Catherine for your work on that section. And the team, I have to say, I think everybody at this table wrote this report. I think we can absolutely say that. That's pretty incredible, so yay. Yay.
Yay. So are we gonna start over again now?
No, we're not, we're still, we have one more section, and then we're, almost there.
So does it make sense to be grouping the disaster stuff that's in the IHSS section C26? All of these sound like vitamins, B10, B2. Does it make sense to have C26 on that are dealing with emergency and disaster stuff, and have that moved together with some of the disaster recommendations that were earlier on managed care?
Yes.
And then I also just want to make a footnote for sport that in this section, C23 is identifying ways to improve coordination and integration of IHSS, specifically retaining it as a benefit outside of managed care, which contradicts basics, a different vitamin.
Yeah. Yes, we have a couple of recommendations that are in conflict. Absolutely.
Good catch. Good catch.
Very true. Yes, Marty.
So, Marty Emoto, City Kent, so this is not specifically about the IHSS part, because it was perfect, right? But one thing that, and Peter and I were talking about this earlier, about and I'm not sure where it fits, but the issue of, and it was raised during public comment period as well, as SSI, SSP, and cost, and I think Jeff, you might have mentioned it too. So we weren't sure where that fits, but obviously C4 talks about the working disabled. Obviously SSI, SSP isn't about, but somewhere that needs to fit somewhere.
Yeah, no, and that is a great question. That's, again, one of those
Or other funny, and then Peter was talking, I don't want to take Peter's thunder away, but, well, I guess I am.
Go ahead.
About other income security type issues, so.
I think that where we were struggling with that is definitely understanding how critical it is for the population of people using LTSS, but seeing that it also deserves a special call out in Goal 4, which is on economic security, the broader Goal 4 of the master plan. So that's where, do you see what I'm saying? Like, again, the focus of this report being LTSS.
Yeah, and that's where we weren't sure.
Right.
Yeah.
But again, everything is so closely linked, it's hard sometimes to make those distinctions, so.
Hey, Sarah?
Okay, yes,
Yeah,
Maya.
this is Maya. Can I just get a comment? I have to drop off in a few minutes, and I just wanted to make
Yes.
one comment about Section C. Under the residential care, strengthening 24/7 residential care, one big thing I see missing, and this came up again and again in the meeting that Kim and Susan and I went to on Thursday night at the town hall, is RCFEs. It's not just the assisted living waiver, it's the supply of RCFEs. It's the mission. And I think there needs to be some kind of recommendation that is, if we're going to have alternatives to nursing facilities, that is one of the best alternatives, and the market forces are really diminishing that supply.
Thank you, Maya. That is a wonderful point, and I have noted it under missing.
Okay, thank you.
Okay, thank you, Maya. Yes, Jeff Tom.
So I read this pretty quickly, and so it may be there. But under workforce, we talk, we always have a lot about IHSS providers and those problems. And we have a lot about various sectors of the LTSS workforce. But what do we say about the private home care workers? They have a lot of the same, they look a lot like IHSS providers in terms of who they are. They don't make a whole lot more money frequently because a lot of that money goes to the entities that employ them. Benefits, they probably do a little better, but they don't do really well. I don't really know what to say about it. We don't have the same control that we do over IHSS providers, but somehow I feel that if we don't address them sufficiently, we leave out an important sector of the workforce.
Thank you, Jeff. That's an important consideration. I would say that there was a recognition in the issue statement in the workforce issue about the demand for home care workers and the projection that will be short 600,000 home care workers. But I really see your point, which is there's really no recommendation accompanying that. So that is something I would love to put on the parking lot right now to have a further conversation about, because this gets into kind of one of these bigger, meatier issues that we want to talk about once we walk through the whole report. Is that good for us to revisit in just a little bit?
Sure.
Okay, great. Any other clarifying questions about Section C? Because then we can move to our final section, D. Yes, Kim.
Quick question. C6 is ADRC,
Yeah.
and INA is up in pathway.
Yeah, I am confused by that as well. And I think, so what, we can clarify that it was, C6 was the ADRC, expanding it as a statewide program was an infrastructure access recommendation, but it should really be potentially in that broader one about where we have under C2. But I think it also relates to the pathways one because it's a pathway to care. So this is one of those that we really struggled with because we see it as the pathway, but then it's also about the infrastructure of the existing system, which is only 8 programs. So, Catherine?
So, to add to that, the intent of the A2 or the INA platform was broader, B1, broader to include ADRC possibly.
It's name checked in there, yeah.
Mm-hmm.
Yeah. Right. But not recommending expansions necessarily.
We're gonna see if this works. It rested. So I get when this is an overarching question, but it was sort of most evident to me in some of the C recommendations. We talk a lot in this section about older adults or seniors, but we don't mention people with disabilities. And then in some sections we mention seniors and people with disabilities, and common kind of voice, whatever words we're going to settle on, we should settle on, unless it's something that's more specific to one group or the other.
So in general, I think, is there agreement that the terminology should be older adults and people with disabilities? Is there agreement on that? Because I agree completely that we need consistency. We tried catching that, but I think it just didn't happen. Is there agreement on that? Okay.
Totally agree. Also on the rural issue, it seems like that instead of using the term rural counties, it should be consistent rural communities. People don't think about San Bernardino, but San Bernardino's got a hell of a big section of rural.
That's really good.
Yep.
Love that. Rural communities, perfect. Okay. Okay, so if everybody's ready, we can move to section D, and I'd like to thank Nina for her wonderful work with the Affordability and Financing Group and the wonderful writers of the Affordability and Financing Group. This is a nice, relatively short section. Actually, it is. So this section focuses first on the individual financing of LTSS and getting at the issue that we've discussed at length about the need for a public benefit to help finance LTSS for those who currently are not eligible for Medi-Cal. Recommendation D2 is going to be removed if everybody's okay with that. This was supposed to get at the state local fiscal structure. Now, Maya, that doesn't mean that there's not a way to address. There is another issue that was raised in this recommendation about health plan funding, and fiscal incentives. I think we can revisit this, but I think that the earlier issue of the concern about lack of incentives for IHSS because the fact that counties pay for IHSS and not for nursing homes isn't really applicable as much right now. There are still recommendations in the IHSS section about the funding formula that are a little more nuanced than just this issue. So my recommendation, if everybody's okay with it, would be to remove this one and maybe address the health plan issues, Maya, under the section, pathways section. So, Ellen.
I would just say somehow to have a placeholder in here because the responsibility for funding these programs is still in different areas.
Yes.
So
okay.
how we get at that
Okay.
and how I think this recommendation tries to talk, or the next one really tries to talk about global
Yes.
budgeting. So anyway, somehow having a placeholder.
Okay, I appreciate that very much. We'll think about a placeholder for that. About funding at the community, funding at the county level in general. Okay. Okay, so that is, any questions on the recommendations in this bucket? Thank you again to this work group, and to everybody. Claire?
Just one question. I'm not sure oh, sorry. Thank you. It's Claire. So the IHSS financing recommendation is right now C21, and it does feel like maybe we should bucket all affordability together, because the other IHSS feels pretty distinct.
Okay, so maybe that goes under the affordability bucket. So C21, again, this is on page 23 for those of you who have remembered. We can bucket this under the affordability financing. Okay, that makes sense. Yes, Ellen?
The other suggestion I would make, we have workforce in a number of different areas, and that is such a powerful cross-cutting issue. I feel like it may need its own area with sub-bullets out with the different, workforce for caregivers, workforce for IHSS, workforce, but to have a more powerful punch, maybe its own section.
Okay, great. I feel like, that's a wonderful suggestion that we can move on. Right now, it sounds to me like we've moved beyond the clarifying questions. Am I correct? Are there any other kind of clarifying questions? Because we can kind of segue into this section of the bigger issues where there might be priorities, the concerns, and the omissions, and any inaccuracies. Lydia, did you want to facilitate this portion of the discussion? I'm just asking.
Yeah.
It's up to you, or you can do it.
Could you
How are we
bring
going
up
to
the slide, maybe, so we could see what...
Okay, so Susan, should we start, are we at a place where we want to first identify the concerns, or do we want to start by thinking, are there general places where there may be consensus, and then working through concerns? Claire, did you have a suggestion on that?
Kind of, but I kind of feel out the room on this a little bit, because I know we want to talk omissions and concerns, but then there's also this big idea piece, and I guess, so I'm in two headspaces. One is I understand people might have very specific things they want to talk about or that they have identified, but my worry is then that's the rabbit hole, right? Then we spend an hour parsing and wordsmithing and getting kind of batting things around. I'm wondering, is there a way to talk about some of the big ideas? Because I think the big ideas might not even, I think this is all amazing and you guys did a great job, but I do think some of the big ideas might lift off of some of this. And talking about that, because then there might be more of a sense of oh, there's starting to be consensus around some of these big ideas, even while there might be concern that B12 has some concerns or whatever.
I think that makes sense. I think I do want to call out so far what I've heard as the big concern areas. One is the IHSS integration, and I'm anticipating that some of the delegated workforce delegation issues. Maybe what we can do is we can get into that now, and then if we want, do we want to call out at least where the big issues are, and then revisit, or do we want to just jump right now into thinking, why don't we start on a positive note? And we will give, how much time do we have here? It's 2:00 and we have until 3:30. So why don't we at least by 2:45, then have some time to discuss issues, but right now we can have a good chunk of time on positive things.
Nice.
Is that good for everyone?
Yes, I want to start.
Wait, Patty wants to start, and then, okay, whoever wants to talk, put your hands up.
Okay, so, because I also have a correction, okay. On page 3, dedicated statewide leadership, I think there's pretty wide-based support for the appointment of a deputy cabinet secretary for aging and disability in the governor's office. Now, this to me is going to clearly demonstrate whether this man is going to walk the talk. Walk the talk is putting a deputy cabinet secretary in his office. But he also is the one who appoints the person. So what we have is designate. It's got to be governor designates. To me, the governor designates the cabinet secretary. The rest of it can stand alone. But it wouldn't be the secretary of Health and Human Services. It would be the governor.
That's right.
Okay.
Right, that's right.
So that's what I have
So
to say.
Patty, what you're saying is that one of your big areas of, one area that you see as really critical, where you think there is consensus, is on this issue of the deputy cabinet secretary, to get at the fact that we really need that, the state leadership at the top in the governor's office. We have wonderful state leadership at the agency level. It needs to be accompanied by
There are several recommendations in this report that if they're not implemented, this is not going to go anywhere. That is one of them. That's like a chief one of them. Like restructure is another one. Like the standing committee in the Senate and the Assembly. Those are real key ones for this to move forward, and that's the first one.
Okay, so I heard you say for the cabinet secretary, I have not heard consensus on the reorg issue for the department. I've not heard that as consensus.
We haven't talked about that one yet. Only this one, I'm just saying.
Right, okay. Right, let's start with the gubernatorial position. That's one we will put it on the list of a potential area of consensus.
Right.
For a big idea. Other thoughts? Claire, I saw...
Wait, but I also...
sorry, Patty, you're not done?
No, I want to make sure that it says, not designate, but the governor designates.
Right, we will clarify that.
Okay, thank you.
We will absolutely, governor appoint.
Thanks. I think there's a couple things that I wanted to call out as seeing big ideas. We've talked quite a bit about, over several different meetings, about the affordability piece and around the financing piece. I think one of the things about creating a universal LTSS benefit may be one of those things that is extremely hard to lift off the ground without sort of heavy duty, like governor level, like I'm saying this in my state of the state, I'm saying this in my budget talks, I'm lifting this up all over the place. So I want to say that is one area to me that feels so humongous, and some of the issues that are really critical fall under it, right? Like you could see a bunch of other stuff slotting in. If you get that, then you get a bunch of other things moving. That's one thing. The other thing, thinking about within a lot of the access issues, is, and maybe some of the pathways, but like this idea of rebalancing toward home and community-based services. So the state, tells the feds how much, how much we're spending on home and community-based services, how much we're spending on institutional long-term care. We've been moving closer toward, majority now is on HCBS. But one idea I wanted to suggest was picking a really high number toward like 80% of HCBS within 10 years or something, that it's a number so you can like say if somebody did it or not, right? But again, then you can't get there without doing a lot of these other things. But then that way there's a big high level thing, but you can keep touting the more wonky, like programmatic things because it's leading toward the goal.
Very cool. Yeah, thank you. Okay, Donna's right next to you and then Catherine after Donna, and then I know there's others. Nina.
Hi, Donna Benton. You said this is positive, so I really like the LTSS section. I think this is really, it comes across as very important. I think this is the one section that will help what we keep not always mentioning, which is people that don't qualify for IHSS. And I think that's one of the, when we've been talking, is people keep saying, what are we doing for the other 90%? So I think the more that as we move toward that benefit, like you said, that's really going to lift up the boat for everyone. So that's the big positive, and would highly endorse that.
Great, thank you so much. Catherine, and then we can move to Nina and Ellen, or Ellen after, I don't know who came first. Okay.
I think I left it up, but I'll just take advantage of it. I mean, I'm just picking up on what was said. I think there is a piece about financing that is the big idea, right? So equality and equity of services ensure that every person can afford to get LTSS services in that broader way, rather than we're pulling out this piece or that piece. So I would elevate it to above a specific. I don't disagree with what you've said, Donna, at all. I just feel like there's something bigger about that.
I missed the first part of what you said, so was it saying that you could make it? What was the first part of what you said?
I think
Financing.
I really was just saying, to me, the overall financing of the LTSS system, so that there is everyone can access a LTS benefit that they need, so sort of under almost equity and equal access. That, and then there's a whole bunch of different ways and things that have to be reformed, but to me, it's just not picking one of them. That's all.
Got it. That makes sense. Thank you. Okay, Nina and then Ellen. Patty, Nina, and Ellen.
Oh, just given what you're saying, what you said, Catherine, and also Donna, what you said, as it relates to financing, the biggest financing issue is going to, and because it plays so strongly into equity, is rural areas, which are missing so many of these long-term services and supports. So that's where a huge bulk of money would have to be targeted if we're really serious about equity. So it's not Los Angeles, it's not San Francisco, and it's not San Diego. It's the rural area. I just throw that out when you talk about financing.
Okay, thank you. Nina.
Can I get I don't know where I can get in the queue.
Oh, okay. Absolutely. Maya, you can go after Nina, and we'll get to Ellen after.
Okay. Nina Weiler, Harwell, ARP. Well, I mean, I'm the second what a lot of folks have said. I really appreciated what Catherine had to say. And the reason for that is looking again at that overarching big picture. When we talk about fairness, and I've said this before, what I hear from our members, these are people who maybe can pay a little bit towards their services, and then they're missing everything else.
Right.
They are the forgotten middle. So what we hear too is people feeling, I pay taxes, what do I get from this? So making sure that everyone in the state, every person, regardless of where they live, regardless of income, education, gender, race, identity, are able to access services according to their need. So I kind of like that as an overarching framework. I'll say one other thing about LTSS. At some point, we're going to have to get away from that. So when we get to public messaging, a little more, LTSS people have no idea what that is.
Right, absolutely. I think that applies to a lot of these issues. Maya, first, before we move to this side of the room.
Yeah, the three ideas that I would vote for are, first of all, what Claire said about balancing. I think it'd be really powerful to have a specific goal on rebalancing, and a lot of efforts can fit under that. The second one I would vote for is the LTSS financing that Nina just talked about, the universal benefit. And the third one is picking up on what Patty said. I would just frame it a little bit differently. I'd say rather than rural areas, I would say that we make a really powerful statement about the need for infrastructure in every area of the state. And that infrastructure means services, not specific programs, but what are the services that are needed in every single part of the state?
Yeah. That, I've heard a lot of agreement with that one as well, and the kind of having a plan to get there, to build it out. Thank you, Maya. Ellen.
Yeah, I just agree with all the big ideas that people have brought forward so far. I would just add, I already mentioned workforce. Without the workforce, not too much is going to happen, and as part of that, the support for caregivers at every income level, paid caregivers, family caregivers. I think that bucket is so key. Those two are so key to having a system in the future. The other is integration. I know we have different views of what that looks like, but we talk about PACE, looking at PACE models. We talk about managed care, bringing in the social determinants of health services. So looking at the whole person and figuring out how we're going to support them with care coordination, no matter their income level.
Yeah. So, I appreciate that a lot. Craig, did you want to talk after? One thing I want to tag on to that, Ellen, is that it reminds me of the fact that, you know, if you think about our graphic, the three buckets under it and the overarching structure of the cross-cutting issues, particularly calling out leadership, all three of these buckets are critical. You can't finance a broken system. You can't build out a system that's fragmented, and if you want to build it out, you have to finance it. So it's all of these elements are important, and so it's almost like we have to call out, in the big ideas, call out something from each of the buckets somehow. So just a thought. Kim, and then who was after? Oh, Susan, you're next after Kim. And then Marty.
Spirit, I think one thing that strikes me, and I'm sure this is, you have to divide the work up and go work in groups, and so you can see where all the Medi-Cal ones came up, and you can see where all the IHSS ones came up, and so the recommendations right now look a little bit organized by who's paying the bill, which is actually not how we want to talk about this conversation. We want to talk about, so I think earlier someone said, oh, the IHSS financing one is, with all the IHSS one needs to go to financing, but I think that's what I'm struggling with, all the Medi-Cal ones being in the pathway.
Right. I agree.
That's not how I think people think about how. So I think there's some who pays is a thread, but what we're talking about is how do you know, how do I find it? Is it there when I need it, and can I pay for it? And if you can try to yes, Medi-Cal runs across, IHSS runs across, Older Americans Act runs across, private pay runs across, but there's something about the way we all work in silos that's showing up in how these are grouped, but I'm not quite sure how to unwind quite yet.
And there's a little bit of a mix of both, because I hear what you're saying about the pathways having a Medi-Cal focus, but it's focusing on it as an integrated service delivery, an integrated pathway, not because it's a Medi-Cal bucket, but it kind of starts to appear that way, is what you're saying, is that it's looking.
Then you have the LTSS standards of care in the other bucket. Standard of coverage.
Access, yes.
Right, and then, standards of access is in your second bucket, but yet your integrated system is over here, and I don't see how you get, so that's confusing.
Yep.
And then the other one is Medi-Cal coverage, just straight up to, am I on Medicaid at all? You have in access, not pathway, but that's your pathway.
Yeah, good point.
So I think there's just, I know this is not the forum, but there's some logic model.
That's a good point.
It's all
that I'm
good
not
points.
Tracking.
I don't know. I agree.
And it made me that.
Want to rewrite it? No.
I'm starting. Nothing was thrown.
You're reminding me.
No, but I was just gonna say, maybe it's that ultimately some of those categories fall away, right? Like, they're useful when they're useful, but if they're like getting us locked into weird, like, semantic arguments, then they're not.
We're talking wonky too.
Right.
Exactly.
Yeah.
Susan, did you have a?
This is Susan with the Alzheimer's Association, and the big ideas that I really like. Definitely the INA. I think a statewide portal. We hear over and over, people don't know where to start, they don't know where to go, they don't know who to trust. They get incomplete information, and it's a scavenger hunt. And I think the portal can take us somewhere that integration and rebalancing will take longer. And it can simulate integration to the consumer. I mean, if we can, in a technological way, we can organize things, then the physical plant, you know, the offices and the staffing can follow. So I would make a big plug for that. Absolutely, the financing, the new public benefit, almost everyone with Alzheimer's is on Medicare. Many of them are on Medi-Cal, and most of them don't have what they need. So people have coverage, and they don't have access to what they need. And so we need a new funding stream. And then in the infrastructure piece, I think if there is more public benefit in the system, we will start to see home and community-based programs grow up in our communities where people today don't have the resources to support them. So on that list of core services, Medi-Cal alone cannot pay for all of those core services. So we need another funding stream to start populating programs and services in rural and urban areas.
Okay, so we have Patty and Karen. Karen, you want to go, and then Patty will go next?
But Marty was next.
Oh, Marty is next. Okay, Marty, Karen.
I don't know, is this the mic that came through on the floor?
Positive?
I wish we could have caught a video of that. Marty Emoto, CD-CAN, family member. So, is this the part where we're supposed to say something good?
Well, this is the big idea bucket.
Oh, big idea.
Yeah.
And, and I like, the various points and everything, but I do agree on the point you raised that we kind of ended up in these silos inadvertently, and I think that's just something we have to work on, right?
Yep.
I think that's natural for us to do that. It probably was important for us to do that initially, but we'll have to work on that.
Yep.
But I do want to mention toward that is people who are going to read this, so I'm talking about the audience outside this room who are not the policy wonks, they're going to look for something that they identify with. And also they're going to look at terms that they have no understanding, or it's been used as a cost containment word, such as rebalancing, which is actually, can be used as a good word, but in the way that it has been used, at least in the last 10 years, it's been meant to rebalance.
Right.
And you know this when you work for the agency, as a cost constraint. So all these words are meant to have dual meanings on purpose, or triple meanings. And so I think we're going to have to really define what those means, or not use those words, so that we say what we mean, right? Because I think that's the other issue, is that policy making doesn't really say what it means. It hides it, disguises what is a cut as something else, and so we just need to be honest, and that's hard to do, because this has to be read by people in policy making who read things in a certain way, and also cost control, trying to look at what's sustainable is a different pathway. And by the way, looking at things here, I just want to stress over, and Peter and I, and Catherine too, to some extent, and actually Lydia, we all deal with people with developmental disabilities, but if my family reading this, they would think we're not in here.
Right.
And I've said this before, for instance, about access to care. It does an overview. It mentions all the other types of services. Not that we want to fall into silos, but you want to show that you're there.
Okay.
And that's an easy thing to fix. And it was one of those things that, Kim, when you were working for social services, you had to come to grips with the CalPERS expansion, right? And making sure everyone was included. Just that's an easy thing to do. It's just.
Yep.
But kudos to everything and fixing all this. Lydia, are you going to do the one?
Yeah, absolutely.
So we have,
I'm waving.
Karen?
I'm waving.
Karen?
Karen's waiting.
Oh, you're waving.
Waving.
Okay. Because I want to, can I say one thing?
Deferring.
Because we have 15 minutes left of the big ideas, and then we're going to move on to issues and concerns, just so people know.
I'll save mine for issues and concerns.
Okay, then we have Nina, Donna, Nina, then Donna.
Hi.
Carrie?
Okay, Nina.
And Dr. Revelo just got unmuted again.
Okay, great.
Hello. So, Nina, ARP, I'm just going to add to big ideas, workforce. Thank you, Ellen. I actually had that on my list and forgot to mention, but the workforce issue is absolutely vital. If we build it, they're going to come. They're going to come to what? Not just the system, but where's the workforce going to be there to support them? I want to go back to what I said before about people, individuals not being able to access services and tagging on to what Susan said. So as we're building a system, not assuming that because someone has Medi-Cal, everything's covered, we know about share of cost, but some things are not covered. Because someone has Medicare, everything's not covered. Because somebody has some retirement security, everything isn't covered. So my best friend, caregiving for her mother who's now passed, with Addison, she didn't have everything she needed. Her mother had long-term care insurance. So, having been employed by UC Davis. So, just being mindful that there's always going to be gaps, and sometimes those gaps are huge. So I just asked, and I know everyone here gets it, but not assuming because you have some part of whatever it is that you don't have thousands of dollars out of pocket.
Yep.
And that includes people on Medi-Cal.
Yep. Donna, and then Carrie.
Okay. Donna Benton, USC. I just wanted to also endorse the standardized screening and assessment. I know we haven't really talked about that. I know we should be careful when we're doing our assessment that we don't, someone, I think June Simmons likes to say that they get all assessed up with nowhere to go. So, yeah, so we have to be careful, but I think that it is really important that at that assessment level, that can also help us with our equity issues, because if everyone gets the same questions, whether or not they ask for it, then that helps toward equity. Because whoever's doing the assessment, doing the screening, you don't kind of make assumptions about what this person may or may not need because, oh, well, they're within this ethnic group and we don't need to understand they have family helping them. But if we have standardized assessments, that will kind of help fill that gap. So.
Thank you. All right. Who was next? Craig? Oh, it was Carrie and Craig.
And then Peter wants to get on.
And then the phone? Oh, Dr. Arevalo as well. All right, Dr. Arevalo, while I'm walking across the room, do you want to make your comment? And then we'll go to Carrie.
Yes, can you hear me?
Yes.
Oh, good. So I just wanted to agree with Ellen about the workforce issue as a big, and to again, I know some of you, probably many of you know that the Commission on Future Healthcare Workforce that was put together a very substantial document that addresses many of the concerns around preparing the workforce, and aging was one of the key recommendations or underlying themes in the recommendations. And I want to make sure that we, don't forget that that's a valuable resource that we could use that has behind it substantial research that supports, developing the future workforce to address, these key issues, and particularly around aging. So, again, just a quick comment about that. Thank you.
Okay. So one, I just want to say something that I think might be a big idea. So there's this recommendation for the LTSS benefit. So this is a front end, very skinny, probably, likely, if it's like Washington, very skinny, 1 year, $100 a day benefit. We also have recommendations in here that talk about encouraging the federal government to come in and provide more LTSS through Medicare Advantage or other things like that. A lot of people who are experts on how insurance works for LTSS talk about the partnership between a front-end benefit and a catastrophic benefit. So if California is coming in with an LTSS skinny benefit, what does that do? That saves Medicare money. So if we're talking about the state of California having some influence into some of these conversations that are going on in the federal government about a catastrophic benefit or coming in with, that's some leverage that California has coming into, how much is this LTSS benefit going to save Medicare money? And then how can we use that as advocacy on the federal level to say, well, what can we do kind of on the back end catastrophically?
Good. Okay, great.
This is Craig, and just a very, very quick point, because I think this is all really good. I would double down again on the workforce issue, like you've heard. I think that's so key to everything across the board. And I think what Susan said, and it sort of ties to what Ellen's saying, we have a hard time figuring out how to navigate all this stuff.
Yep.
So something, to me, a really big idea is just how do we set some system up so that individuals and families can just figure out how to navigate. And that, to me, is something we could do. I don't know, through websites or whatever. Yeah, the INA, it's really the INA. I think that's really key. But I would also, I appreciated what Ellen said about the organization. I'm not smart enough to know how to fix that at all. But I think it was a really good point.
Okay. Claire, did you? Peter. Perfect. And then Claire. And then, Okay, then we're going to wrap up.
Greg, following on your comment, first, my name is Peter Mendoza, Consumer Representative. this is what I think, at a comprehensive information referral, no wrong door system would be, is really important on all of these issues, because all the issues that we've been discussing kind of intersect the need of, once we have the systems in place, we have to help folks navigate the system so that they understand and so that they know what services are available and how to access. For example, Susan mentioned that people, with Alzheimer's have Medi-Cal, and then they also have Medicare, but they still don't know what they mean. And that's partially because there's gaps, but partially somebody could help assist them or the family and help them get the services they need. One thing I am concerned about is that I want to make sure that the public, or those who are going to give public comment, really have a way to navigate how to do that in a very short amount of time. And I can read this document, pretty much understand what we're doing, because I've been at this for a while. I am concerned about those who may have not followed as much, or may have a lot of knowledge but may have difficulty understanding how to give the best comment. So just as we move forward, I want to spend a little time on how we're going to make this accessible for everybody that will want to comment, whether it's immediately or down in the process.
Thank you. That's a really important comment, and I've marked it for the a point to discuss about making it accessible in terms of how readable it is, but also accessibility in format and design. So thank you for that, Peter. Okay, now we are moving to Claire, and then we might want to begin to try and summarize, so we don't want to shortcut the issues that we need to discuss.
Okay, thanks. My question is actually around when people say workforce, I know they mean more, better trained, all these things, but is there sort of a concise, goal of the workforce? Like, we will have, enough trained, well-paid workforce to meet the projected needs, or we will have...
No.
I don't... But I guess, because I don't do workforce as much, that is something I'm having a really hard time articulating, what the goal is, or the big idea is.
And there are a number of very big goals or ideas in this report, but I do agree that we have to figure out how to refine it so that it's a doable big idea. So that's something I think for us to think about, because I hear what everybody said, which is we can build out this whole infrastructure if we want, but until we address this workforce issue, you're not going to have anybody to fill the infrastructure. So, okay, Karen, and then we will try and summarize. Susan, did you want to comment?
At the SAC meeting last week, Dr. Galley, I think, noted that both transportation and housing didn't seem to be addressed enough, maybe in the infographic or in our priorities. And so I don't know how we respond to that, but I feel like that there was an expectation that we would.
That was going to be one of my concerns. It's not there in the report.
I thought he said it at the SAC last week.
No, it's an issue I'm going to bring up as a concern.
LTS. Go ahead, Sarah. I know, I was just going to say, the discussion we've had is that, yes, those are critical. These are one of these cross-cutting, it's an issue that impacts access to LTSS for sure, but the general issue of transportation and housing is so ginormous, it's not necessarily in the purview of the scope of this committee, and it falls under the goals of the age-friendly communities. Kim, did you want to speak more to that?
I mean, to tee up that the next 3 webinar Wednesdays are housing, transportation, and homelessness. That's the Goal 2 work group reconvening to begin on that. So I think that there's a way to nod that that's critical, but also that's the Goal 2 work group.
In the report. Yeah, thank you.
It's February.
Yeah. Okay, good. That's an important point to nod to in the report.
For clarification, though, because the concern is when this was going to be set up, I mean, he was going to be meeting, you would be meeting with all these departments. That's what has to happen. Those departments aren't even mentioned in this report, as far as I know, and they need to be. This needs to be a state master plan.
This isn't the plan, though.
This isn't the whole plan.
This is our report.
This is
The bigger master plan, it will be, I think Kim said it will be a bigger master plan.
You know what I'm saying, Melanie.
Nina Harwell, ARP. So, of course, we're about to, as you said, the stakeholder, as Kim said on Monday, last Monday, we are pivoting to the whole master plan now. And that includes a whole section on age-friendly. Got it. Including housing, transportation, built environment, everything. And both, it's really important that it fit in here, but the big picture with interagency cooperation in terms of age-friendly is going to happen, and that's how ARP sees it, in the back half of the whole master plan process.
It is happening.
Yeah.
Right, not the same.
Okay.
Peter, as a consumer representative, I think it should be mentioned though,
Yes.
so that we can say where it is, because as Tip, I'm old
That's
enough
fine.
to remember Tip O'Neill. Tip O'Neill used to say all politics is local.
Local.
And so if we don't mention housing and transportation,
Yes.
which are really key to a lot of us, then people are they're gonna wonder why, and they're gonna ask questions. So I'd like to direct them as to how those two issues are, where they're gonna be
Right, they're gonna be.
parked.
Definition of LTSS.
Yes, there is. There's a definition at the front. What I think we can do with these issues is these can be themes that are really called out at the beginning of this report and even in the executive summary of recognizing the interdependence of these broader social determinants on the LTSS service delivery system.
Okay.
But I think at this point, given time, unless there's any really big concerns about it, I think we need to make sure we give time to the issues and the concerns that people have. But I just want to make an attempt to summarize some of the themes we've heard about big ideas, and I don't think we're going to come to a final decision right now. I think we should think about it for a few days and figure out if we can reconvene somehow, maybe at the end of the webinar to discuss this. But these are the big ideas I've heard. One, overarching all of this is leadership at the state level, because if you have that leadership at the state level, it really paves the way for broad-scale system change.
Exactly.
Again, people can push back, but that's what I heard. Two, is the financing. We have to shore up the financing of the system. I heard this was overwhelming in here, is the financing. And with that, I think you could easily tie in the rebalancing goal if you talk about financing. You could, because rebalancing is really specific to Medi-Cal services for the most part. So I think you could have rebalancing goal as part of a broader long-term care financing, LTSS financing goal. The third is the pathways issue, and it's specifically looking at how people get what they need and how they get their questions answered. It's the people who are completely confused and don't know where to start or where to go, and that's building out the INA along with the assessment to group the INA with the assessment, because if you do INA, you have to somehow assess the people and screen them. And that helps them enter the system and get at least where they need. It doesn't fix everything, it gets there. Fourth, overarching all of that, is the workforce. And we have to figure out a way to refine the recos. If this is one of these big ideas, we have to figure out a way so that it's not so big of an ask that it's not an ask, but that it's still a bold ask. So that's something that maybe we can all think about. And then fifth, I'm trying to figure out where infrastructure and maybe within infrastructure is the integrated infrastructure, but infrastructure has to be in here somewhere. I mean, again, that gets to the access issue. So that would mean doing the LTSS access standards along with an infrastructure development plan that's a public-private approach. To me, those are the big kind of themes and buckets and ideas. I don't know if that's bold enough or big enough, but I think that those could be the main themes that are raised out of the report based on what I've heard. And I want any quick comments to that. We can table this discussion if we have time at the end of today to talk about it. But is there any quick comments, Susan? Did you want to?
I have one. This is Susan with the Alzheimer's Association. So we took a stab in this document of naming 5 on page 2. They've got arrows. This is very affirming. What is not called out per se is IHSS. So I just want to be sure with the executive order, do we want IHSS to be a standalone, or do we want to embed in workforce? Do we want to embed in financing? That's a decision that we're going to have to make.
That's a good point, Susan. That's a good point.
What's not here is INA.
Uh-huh.
Well, INA is, it's the statewide.
Oh, that is
Yeah,
there,
yeah.
that's right there, okay.
So this is
Doesn't have
consistent,
workforce.
this is, we're mirroring back what was put in.
It's missing workforce, though.
So it's, Catherine Blakemore speaking. I think sometimes reframing things is really helpful for moving forward, in that if we continue to think about buckets in the same way, we get stuck in the same buckets. So I think the way I would handle that is to be clear in the report that IHSS, I think we even said this, I think, like a critical foundation for a long-term care services, but we have like proactively decided to include it within a larger sort of system redesign, so that we can be attentive to how it was framed, but then think about it in the way that we think it should. The only place I got lost a little bit, Sarah, was what goes in infrastructure? What were you saying?
Well, it's what was called out for the main component of infrastructure as a place to start is developing the core service mix and building an infrastructure development plan so that across the rural and urban communities, you can reach a core service mix. So it's essentially building out a statewide infrastructure.
And workforce could or could not be part of that, could be under that.
Right.
Workforce could be part of it, yep.
Be part of
Yeah.
it.
Sure.
I don't know if there's,
We could just like run around with each other. So, with so there's so in our original infographic, we talked about a bucket called access, right? And so where does this access issues, that's in,
I don't like.
I think,
Access standards is what you mean, right? The statewide, community by community core, core mix, is that the word you
Core mix access standards sometimes sounds like a health plan word, so that's why we're trying to use core service mix.
I'm fine with that.
Yeah.
I actually don't think infrastructure says that.
Okay.
And so we should think about if that's what we mean, if it's access to services and you need infrastructure is a strategy to get you the access to services. That's how I would probably frame it, but.
Okay, very, very helpful. And I think what we can do is summarize it, and represent it to the group again to continue discussing if we have time today. If not, maybe at the webinar. Does that work for folks?
Yeah.
Because I think we're getting closer, but I don't want to rush us to finalize before we're ready. Is that okay with folks if we kind of take these themes, bring them back to everybody, and then revisit the discussion? Good?
Yes.
Kim?
Can I call it gaps, just, or not gaps yet?
Yeah.
That's where we're
We're
going.
about to move into concerns, gaps, omissions, that kind of thing.
This is the big five.
Yeah.
You all and we all have spent a lot of time in partnership with DHCS and the process formerly known as CalAIM, and that's not in your big five anyway. Or is it within the statewide core mix? But which is not one of your big five ideas right now.
Correct. I mean, it falls, this is gets to what,
Can talk about integration.
so this is a
Strategy for access.
so what Catherine is saying is it's a strategy to get there. I think that it's a good point that we need to put an asterisk in and think about, sit on it for a few days, because it is about the future of our service delivery system in the state for vulnerable older adults, people with disabilities who are lower income, so important.
So if I can just sneak, I'm not sure where I'm talking now at this point, but is it, where are we?
We're not at concerns yet, Marty.
issues, but we're about to right now.
Okay, so I'm straddling, which is, I never pay attention to any of this, but, first, I really strongly support what Catherine was saying about the IHSS. I mean, it was mentioned in the governor's order. I think we do have to address it, but I do think the way that you suggested, Catherine, is the right way, because it points back into the big areas. But it does need to be addressed, because he or the administration did point that out in two ways, stabilizing and the high cost. And then the other things, again, I just want to reemphasize, just mention the other types of services whether it's supported living or other types of home care or other types of services without getting to the trap of the silos. 'Cause
Yep.
I think we're trying to,
Move away.
we started from the silos because that's where we all come from, but I think you're absolutely right, Kim. We got to
Jeff.
figure a way back, so.
Okay, great. Ellen and then Jeff.
And just back to the point of integration, I think one of the recommendations, I can't put my finger on it right now, talks about a long-term plan, like a 10-year plan. So I do think that is one of the big ideas. Granted, we punted it down the road a little bit, like 10 years down, but I agree, it needs to be included.
Good, all right, well, I put a big star next to that one. We will figure out how to revisit that. Jeff, Tom.
So I agree with Peter to an extent on silos, but I disagree in part because there are some services that are mentioned so infrequently that people even don't know much about their existence. And I think it's important that services like that do get called out in this report so that the public, the governor, all of the, constituents that this report is going to will hear about them. Even if they only have one mention, it's important that some of these underserved populations whose services are not normally discussed have some degree of play.
Yeah, thank you. That is an important point on ensuring that we call attention to the underserved, the programs that don't have the resources that they might need. And perhaps it can be defining through, also at the end, lists of different services and programs at the local level. But I think that the point is well made and that we can figure out how to weave that in, Jeff. So thank you for that. Okay.
And concerns.
Yes. Now, we're going to switch, just to finalize, we will get back to everybody on this, summarize kind of the key themes that we heard as the big ideas, what's still unresolved in terms of integration and resolving kind of terminology and how we get away from our siloed services approach and buckets. So moving now to this point, I think this would be a really helpful point to do two things. Is one, to talk about, have really good discussion on what are the big issues that people have real concerns about highlighting in this report. We've heard one from Karen about the integration of the potential to pilot and integration of IHSS. We've also discussed about some of the workforce issues, and I think there's a lot of disagreement in some of the recommendations on 24/7 residential care issues that were highlighted. So with that, I'm going to pause. Karen, I promised you would get to go first on this section, and then I see Claire, and I'll just start making the list. And we'll use this first time to just listen to all the concerns, and then we'll figure out what to do with it. Okay. Unless people have other thoughts.
So on IHSS and integration, I made a statement earlier and I saw some of you disagreed. I thought that there had been a discussion about excluding IHSS from the topic of integration, and the way that I thought that came together was at the December 17th meeting. I wasn't there, but I read the transcript. So again, I may have picked up the wrong sort of tone, but at the beginning of that, there were some broad principles that were put forward by the people that were the meeting planners, one of which was not to make it clear that there would not be an integration of IHSS into managed care. There were a lot of consumers that had been reaching out through the IHSS Coalition, through Facebook pages and so forth, expressing a lot of fear about that, which I think was people that were conflating CalAIM and this committee. And so I had thought that the discussion on December 17th led to a conclusion that was an equally shared principle.
Okay, and I want to say, Karen, what I forgot to mention is that Maya really wanted to be here for this conversation. She had to step off until 3, so can we revisit it as soon as she gets back on, or?
Can I just do a point of clarity on state
Yes.
communication on that point?
Sure.
I don't even want to have a content discussion, I just want to do a process discussion, and Debbie, perhaps you can help me on this too. For what it's worth, here's what I think, and then we'll figure it out, what actually happened. I believe that DHCS CalAIM process, I'm going to call it CalAIM because it was CalAIM when this happened, and it's shorter, said that topic is not under consideration for CalAIM. As part of the CalAIM process, they're not considering, is that a fair statement, Debbie and other folks?
But CDSS said it too, right? You've been saying it at your
Well, I
listening
mean,
session. Right.
they repeated, you guys repeated that.
That's right.
I think clarity was made that there is no proposal on the table to make IHSS a benefit under managed care, either through CalAIM or any other entity. And just a personal aside, I think there's a difference between making IHSS a benefit under managed care and doing some level of coordination and integration of services working with the managed care entities, which I think could be of great benefit to a lot of the folks that we serve.
Okay. Yeah, that's the difference, and that was also something raised in the report as a recommendation. So if it's okay with everyone, before we go down this issue, which is really important, I want to have a good time for it. I want Maya to be able to be here since she, this is an issue that matters a lot to her. So we'll put a hold on that for now, but we will talk about it. Yes, Claire.
Oh, so this isn't, I'm not sure if concern is the right word. How do we make sure that, obviously we want to keep thoughtful recommendations. We don't want to lose all specificity and just come up with like a bunch of platitudes. But also, how do we not just make this a humongous laundry list of things you could do and then, we're giving no... Here's my concern. So I know a lot of you are on SAC, so this is less likely to happen between LTSS Subcommittee and SAC, but as things keep going up, if there's no prioritization, and I'm not saying we're not going to ultimately, but I'm just worried if it's a huge laundry list, then you lose all ability to weigh in on what people pick. People could say, I don't know, I like 4, and then maybe 4 was like the thing. 4 seems easy. Yeah, or 4 seems free. So I just, one of the things I feel like I really appreciated Susan, you saying, being bold and a little provocative, because if we just say, here's a lot of things, then we could be very sad with what ends up getting pulled. And we might even say, oh, it never happened, even though they could say, oh, yeah, no, we did what you said on 16. That's the thing we did.
That's the one thing we did.
Yeah, exactly.
And it was free.
Yeah, so I just want to make sure that, we're really, even if it's tough, even if it means our own sort of issues that maybe our front burner issues for our own organization don't end up being the top priorities, that we do find consensus to some degree as a group to say we're elevating these big things up and we're not just letting this be a really long list.
Great, thank you. That's really helpful. Donna, and then I see Marty, Patty, Nina. Okay. Oh, Brandy too. Okay.
Okay. Donna Benton, USC. I don't know if this is a concern or a gap, but I had a couple of things. One is I'm not sure that we have enough in here around behavioral health. I just don't, and it's part of LTSS, it's part of what goes on, it's part of across the board, and I just don't see it called out enough.
I had the same question because I was we haven't talked about the older adult system of care and Prop 63, and that was a question about whether this is the place to do it, and is it getting addressed in other areas? Because it is, as you said,
I mean, just for example, among caregivers, high level of depression. So
right, I know. I totally agree with you. I mean, that was going to be one of my issues.
So I don't know. Maybe I'm off on that.
No, you're not.
So I want to call out behavioral health. The other thing is around the issue of protection and justice across the board when we're looking at LTSS, that in some way, I don't know if we have statewide, I don't mean ombudsman like you do in a nursing home, but at a really broad level of making sure programs that when people have problems with the red tape, because no matter how well we build this wonderful system, no wrong door, there's going to be problems. Mm-hmm. How do we have a way of people finding somebody who's a neutral party that can help them when they have these problems with this whole great new thing that we're building? So,
care navigator type thing?
Beyond the care navigator, more of a big, real,
Okay, got it.
I call it ombudsman. It's a really big level of ombudsman advocate.
Great.
So that's it.
Thank you very much. All right, we now have Marty. I have on the list. And then Patty, and then Nina, and then Brandy.
Thank you. Marty Yamamoto, family member, CD Can. Just want to echo what Claire said, and one other a few others have mentioned about being bold and making sure, and workforce seems to be one of those issues that is out there, and then the financing for that. But, I raised this in the IHSS work group, or sub-work group, but it needed to be brought up higher, and that is there a need to have work groups, or the recommendation that some of these things we need to drill down for? I think I saw a few of those, and just because there's a lot of, not details that need to be filled in.
Absolutely, yes.
And then, I do think the thing, Peter, that brought up, but a few others again, is when we bring up points, but it needs to be somewhere else, like on the issue of behavioral. It's just that if it's like a pointer saying it's over here, so that we don't keep recycling the.
I think you're right. I do think that
But
it would be helpful to know, Kim, is there a place where behavioral health issues are getting addressed in the broader master plan work group process?
Well, Maya and Leandra and other folks, SAC members, Maya also and Leandra Harvey, are working on a webinar on integrated healthcare in the sense of health, behavioral health, physical health, dental health, that kind of health.
No.
Not
Maybe.
LTSS.
You know what?
No.
And there's the second one. So behavioral health is everywhere, just like dementia. There's also one on loneliness and isolation and depression where behavioral health is coming up. So it's in 2 places.
It's got to be part of the basic service mix, Sarah.
Sure.
Part of the basic service mix.
Okay, so we all understand, we all recognize the importance of it, but I'm thinking for purposes of this committee, we're not ending this committee when the report, in March. Maybe we can have a meeting that focuses on issues of, LTSS and behavioral health access, gets at the issues of older adult system of care in the mental health service delivery system. It's just a thought. Is that going beyond the scope? I'm just throwing it out there. We don't have to discuss it now, but it's, in the meantime, we have flagged it as an issue that's missing in the report, and so, okay, Patty, and then Nina, and then Brandy and Lydia.
Okay,
and Susan.
Well, I have 3 things. One is exactly this subject. I submitted a recommendation on the basic service mix for rural areas. And I had 12 what I call basic service mix. And that was put together by providers in my community who've been in the business of service provision for elders for the last 30 years. Many of those services were behavioral health. Mental health was one. Primary care physicians was another one. And when my friend Lydia wrote it up, she said, I don't think we should keep behavioral health in. They should go somewhere else. Well, I don't like the way it's written in this report, and I want behavioral health in. It's really important for rural areas in terms of the basic service mix. Okay. 2 has to do with INA. We've been providing INA since 1980. We've had a statewide number before. It didn't do crapola. It never did what it was intended to do. And it's not going to work now unless we have got really well-trained people on the ground. And right now, I don't believe, maybe with a few exceptions, many area agencies on aging are putting much money in to information and referral. And they've got volunteers answering the phone and reading from a directory, go to this service. So that you don't have a professional on the ground. You may have the professional at the statewide level, but it won't work unless you really put some money in it on the ground. So I had another recommendation in there about, it's another assessment issue for the state to be able to assess what area agencies on aging and independent living centers are doing currently, who's staffing, how much have they paid, what kind of training do they have. I mean, there's a whole bunch of questions that we have to get at before we push for this mega INA, and nobody knows what information and assistance means anyway. It's never said what it's supposed to do. So, you can put together this great service that San Francisco has, but people don't know what it means. We've been doing it for many, many years, before some of you were even involved in the field. Or bored. All right, okay. And the last one is a concern. If we move forward, we move forward into this master plan, about doing, yes, about a restructure, no longer a Department of Aging, but now a broader department, replicating what we have at the federal level, and there is a recommendation there, and I don't know how much support there is for that. But if we do, what I would appreciate, and I know it's in the recommendation, is for the state to identify and bring in experts that have done this in other states. So we're not trying to create something out of nothing. And there are some states that have done some really good modeling, and that I'm sure would be happy to help. So those are just three concerns that I have in terms of moving
Okay,
forward.
and thank you, Patty. Some of this gets to the issue of, in terms of level of detail per recommendation, and this gets where it gets hard, and we might need to have direct links to full recommendations so that people can see that. But what would be helpful is if you could look at it and specifically indicate what you think is missing and send the comments to Carrie, so that we have the log. I want to go to Nina, and then Brandy, and then Lydia and Susan.
Can I get in this is Dr. Revel, can I get in the queue as well?
Yes.
Thanks.
So this is Nina Wilder Harwell, ARP. I just have something quick to say because I kind of said what I wanted to say. But I know we had a section on data in here, and I believe it isn't just data. The California Health Interview Survey, continuance of that particular survey question was embedded in the LTSS financing recommendation. If we're going to do a section on data, I'd like to pull that out and put that in there. So that funding runs the current cycle and then 23, 24. So calling for permanent. Do you want me to send that?
Yeah, you would be helpful if what you could do is look at it and like actually do track changes and send it to the to email so Carrie can get it. That's one of these editing things that will be easy to plug in, I don't think.
Something else would be really helpful when you send it to the engaged email box, you put LTSS report in the subject line. And also say in your email what recommendation. This is C4, this is A14.
Okay, great. Thank you. I've heard that we have Maya back on the line. So what I want to do is we have Brandy up next. It might segue perfect into Maya. So Brandy, and then if you can summarize kind of what was raised before about the IHSS, and Karen, you can jump back in too. And then Maya, we'd love to hear from you on it.
Thanks. This is Brandy with SEIU. So I'm sorry if this has been hashed out, but the LTSS report is going to have a set of recommendations. Will those remain as standalone, or will they be folded into the overarching NPA?
Yeah. So the report is the first deliverable to March from you all, the administration. This committee is welcome to continue on making recommendations to the master plan through the process, and there's actually a SAC process group meeting to talk about sort of when would be the last time, and then the master plan itself will come from the administration. So it could well be, this is something that's starting to go through my head too, is what you produce in March, what you produce by end of June, and what then the administration produces by October might be three separate things. For sure, the March report from you all and the October report from the administration are two separate things. Whether there's something more you want to do with a little more time, or if you've had it and you're done after March and but because you've already comprehensively, yeah. But I mean, in terms of the sort of, do you focus on the big ideas for March and then fill in, and or do you really try to land this all? I think you've got some important process questions ahead of you as well.
Yeah. It can't be indefinite, that's all I can say.
Only one can work in.
Yeah.
The battery is also.
Okay. So just to that point, I think that this report does a really good job, this first iteration, of identifying the problems and potential solutions. I think my observation from today is where we're getting a little bit stuck is trying to put out a report that has all 50,000 steps that are going to get us to those solutions. And I feel like we're kind of potentially getting in our own way there. So I just want to, I don't mean that as an offense to anyone, but just kind of a temperature check for our own process, is maybe we can step back a little bit. I think if we are really solidly outlining the problems and the high-level solution, we don't have to have all the steps by March 1st. So I just wanted to flag that as a process. Maya, now that you're back on the line, the issue that was raised by Karen is her interpretation, which I would agree with, that both through the CalAIM process and CDSS has said there is no proposal on the table to integrate IHSS into Medi-Cal managed care through what was called CalAIM, and I don't know the acronym now. Healthier. So that's one piece of it. I mean, where I would like to sort of piggyback on that and potentially hear from you on all of these things, is I think from SEIU's perspective, where we would want to explore around IHSS and Medi-Cal managed care is in lieu of services proposal, and if IHSS could sort of be a first choice as an additional benefit through in lieu of services, what that would look like. I know that in CCI there was some authorization that the plans could add additional hours, but there was a lot of questions around how the provider would be paid, et cetera. So I just want to flag that as that is a little in the weeds, but I want to just raise it up. That's one of the questions. And then around B8 number 2, around the contract mode, particularly for those that are non-self-directing, I think that, again, this is the place where Christina sort of passionately discussed contracting standards in our last subcommittee meeting, or one of them that was last week or the week before. This is a place where we would fully support real contracting standards. If the state is going to, or Medi-Cal managed care plans are going to explore increasing contract mode, the unions were very opposed to sort of a all-out expansion of contract mode across the state. We understand that it serves a purpose, but ensuring that if agencies are going to be doing business with the state for the provision of personal care services, that there are contracting standards that drive towards good actors in the market, and that there would be a cap on the number of hours or caseload per county that could be performed through contract mode. So I apologize that those are a little bit in the weeds, but I think a discussion around the greater standards is something that's missing a little bit from here.
Okay, well, this is Maya. I'm not sure I understood all that, but I feel like I missed something. But, you know, the proposals I made were around, first of all, the state. You're right. I mean, the DHCS has not proposed any integration of IHSS, and what I was proposing is some integration on a pilot basis. I have vetted that with our local stakeholders, including the chair of our commission, who's an IHSS user and a chair, and they support it. So I'm reflecting not just my opinion, but, you know, of our local stakeholders. And I understand the huge sensitivity around that, and it is frustrating me around the contract mode. I get it about good actors, because in our county, we had one, you know, before there was a contractor who, you know, for years who did not perform very well and wasn't good quality. And then we did, as I say, contract with Homebridge and had a good experience. But my fear is, and you know, that we have members that are not they're not getting the IHSS services they need. Trying to figure out a way to help them and to help them stay in the community, and that's the purpose of my recommendations. I'm not quite following you, Brandy, in all the contracting standards. You know, I think it it is very telling that, there is no other county that, as far as I know, that uses the contract mode. You know, that is the best solution I've seen so far for the members that we can't, that we're not able to serve, or I just should say isn't able to serve, at least in our committee, in my observations. So, yeah, I'm just kind of wandering here because I'm not sure exactly where we are with this discussion, but those are some of my issues.
Maya, thank you. I think what we should do, we have 15 minutes left, and we have a number of people that still want to make comments. So this is a really important discussion that I think we should revisit, and we will huddle to figure out when that is and how.
Okay,
but I think we should, for sure, with the folks involved that want to be part of that conversation. Does that work?
Yeah.
No, Karen? Wait, hold on.
I'm okay with this being tabled so long as it can be made clear between now and March 2nd how it is that we're going to deal with some of the most controversial and divisive recommendations in the proposal.
I agree. I think that that's a very important point that we need to think through, but that we don't want to rush it right this second. So I agree, and I think this will apply to a number of different issues in this report. So we will revisit that in the webinar in 2 days after we all can think some and maybe huddle a little bit. I don't know. We will revisit it for sure, very soon. Yes, this is a LTSS Subcommittee webinar. Everybody has it from 8 to 10, and the idea was to have more time on the report. It is with the public, yeah. Okay, you're right. All right, let's make sure we hear from folks right now, and then before the wrap-up of the day, we can revisit how to continue to move forward with making some process for working through these controversial issues. Hold on.
Yeah. So I think that this is probably, like, I would step out on a limb and say if we don't have this conversation right on the 30th, this entire thing will blow up.
Okay, but we have a process suggestion.
So there are people that are expert on this issue and the various push and pulls.
If people are speaking, we can't hear it. It's very, very low.
Okay, Dr. Arevalo, thank you. Apologies for that. Now we have a live microphone. Essentially what our next step is, a work group, a subgroup, Karen, Maya, Brandy, to talk, if possible, ASAP, and Catherine and Claire, to start this conversation and to come to resolution because there is concern that this could disrupt the process moving forward. So, with that, is everybody okay with that as our next step? Okay, thank you for that suggestion. Where are we with this particular IHSS issue? The committee is talking about the recommendation. There has not been consensus, and that is being actively discussed, and that in the very near future there will be the next draft available that shows where it is. Yes. Yeah, we're working through it.
This is Marty. So in the previous meetings at Cal-AIM, as well as the previous meeting that was focusing on IHSS, on that issue about the issue of managed care benefit and IHSS was pretty much made clear there was nothing on the table being proposed by the administration.
That's right, for calendar.
That's what people think. And the reason why, Karen and others and some of us are raising this is there was a lot of issues raised on the various listservs, and then we went back to a lot of these people and said, no, there's nothing on the table.
Right, we understand completely. I hear what's being said, which is there's concern because there was a perception that this group wasn't going to address it. I don't think everybody shared that perception, and again, these are recommendations in the report right now. This is not the master plan and it's not the state. So what we haven't come to is consensus on the contradictory recommendations in the report on this issue, and that's what, in the next few days, we'll have. As of today.
There's nothing on the table coming from the administration
Oh,
either.
nothing from the administration. Nothing.
And that's important.
100% nothing from the administration. Okay, is it okay? I'm concerned about hearing from folks. Are we okay?
I'd like to start to bring it back to some process, because I'm starting to.
Oh, okay, Kim, you want to make a point about process? Hold on.
Let's just. Thank you. So let's just take a breath. 3:20. We need to spend a few minutes summing up where we are. I know we have sort of action steps, and at the end I'll do that. But I'd like public comment to open at 3:30, so we have our usual 20 minutes on this topic. Sometimes we have more, sometimes we have less, so we may have. But I want to just check in on the best use of the next 10 minutes. Susan and Sarah, what would be helpful to you at this point? You've heard a lot about particular issues, about framing, about big ideas, about gaps. What would be helpful for you to hear from either the state or from your subcommittee members? Okay, let's have that. I would like to have that conversation. Can you? Oh, look, I have the clicker. I could do it. Okay. So because calendaring is such fun, there are times that are already grabbed, and I'm hoping you all have these Outlook invites. If you don't, let us know. We already went ahead and said, let's have a webinar on the 30th to walk through the initial draft report. So one question for the group is, if there's a webinar on Thursday, what's the best use of that will be helpful to the public to understand the ideas and also to inform this process? I could imagine a couple different. One, present it as is. Two, take in this robust conversation, think about a different higher level presentation. And I'll be honest, there's also a cancel, let's make sure it's a value add for people. It could be shorter. I mean, it really is. So I think thinking about what's the best way to engage the public, if that's the intention, and I think we also need to have some clarity with you about whether it is a subcommittee meeting with public comment or whether it is a public presentation with people questioning and commenting, like Zooming, like the webinars have been. It's a subcommittee meeting. Okay, it's a subcommittee meeting, like all of our subcommittee meetings are open to the public and public comment. So understanding what the best use of your time together virtually for 2 hours on Thursday morning, so that I think there's some, we also have the 19th held as some time to let all of this settle, all that you heard today, to hear it, to take it back, to have small groups on topics. So we could also just drive towards that. There's so much gesturing happening in the room. I wish we were. Next time we'll live cam.
I think we were just saying
all kinds of signals of if I can interpret the signals right. The signals I'm seeing are along the lines of cancel the webinar on Thursday because the public has heard the report today. They have seen the report today. They have time to comment. This gives people more time than 24 hours, to Peter's good point. This is a lot to absorb. That having a minute, and then we would reconvene as planned on the 19th. I have to look and see if we have a half day, a full day in person, or what we have for that day. But that would give us more time.
Yes, that's right. The subgroup.
Violate my own protocol. So it's Catherine. A subgroup could meet to use a portion of that time, maybe starting a bit later, because I know it's hard for some people to join at 8. They have children drop off. Yes, if we're not meeting on the 30th, we have it on the calendar. We would just use.
The state would back out, and some of you could organize a work group with that time.
We could just have our little small subgroup since we all have the time reserved. And my only suggestion is that we start a bit later so everyone can participate.
And my only thing to that is, I think however you all want to move forward with the IHSS one, whatever timing works is great, but my concern is that we make sure we have flagged the other issues that need the similar attention. And I don't know if we got there. Lydia?
On another issue that we, as we met yesterday, discovered was pretty controversial was the recommendation by the Welfare Directors Association to integrate AAAs and ADRCs within the county structures. So that I've not heard discussed ever in a public setting. So I think that's another biggie to flag for discussion before the 19th. I don't know how that would happen. And the only other thought I had listening to everyone today was with the big picture or the big, bold ideas in mind. I started to think, because I probably won't be active with you guys in 10 years, hope to be very retired by then. You know, what in 10 years, looking out at California, what is it that this group would have recommended to the master plan that would have been adopted that would truly have made a difference in people's lives? And that we could say, I am damn proud, you know, that we came up with those big, bold ideas that got adopted and actually got funded and implemented, and we have research to back it up and metrics and all that good stuff. So maybe if we can kind of imagine and think that and work backwards on what would be those big, bold ideas. Because the hows, there's a gazillion hows to get to the end, right? And different pathways, and we are not in control of all of those. But we certainly are in control of what that vision should look like and what we want, what we hope for that 10-year milestone to look like. So I think that's how I'm going to begin thinking about this anyway.
To go to the queue, we do have Susan and then Peter and Dr. Arevalo. You're okay. Peter, did you still want to make a comment? Okay. And then Dr. Arevalo on the phone after Peter, and then we'll go to Maya, Nina.
Hi. Just wanted to make a brief comment. Again, it was back in the workforce issue. You know, geriatric training is only kind of commented in this preliminary draft 3 times that I could find it, and it's a huge issue in terms of not only for professionals but for paraprofessionals. And want to make sure that that's called out, you know, and not just actually for medical students and mid-career physicians, but actually at the level of, you know, and more than physicians. And also, very little, if any, in terms of discussion around end-of-life and palliative care, which are really significant issues that we need to call out in terms of addressing workforce for, you know, a large segment of our training issues. So, wanted to make sure we don't forget about that.
Yes, and this is an inadequate answer to that, but both of those are contemplated currently in Goal 2, currently have dedicated webinars to each of those topics, but that is not to say they shouldn't both and be called out in some way here.
Very, very good point. Okay, thank you very much, Dr. Arevalo.
Just briefly, I do think even though behavioral health may be covered in other venues as far as the best upon aging, it does need to be called out for LTSS too, because it's an issue that affects both recipients and providers. And we need to make sure we call it out or at least mention it and tell people where to go. And I'm going back to the earlier discussion.
I have Nina and Karen and Ellen, and so we're going to have to all just...
Everyone gets 60 seconds so we can...
So maybe I missed this, but we do still have to have a discussion about how we prioritize, and I'm not sure we've settled on that. Is that Thursday?
That's what I'm going to try to do.
Okay, got it.
Okay.
That is the question.
Now we get, I have Karen and Claire and Catherine. Do you mind if we just go straight down the line here? Or do you want to go first, Karen? Karen was first.
This is my cheerleader thing. Back in 1992, the state did a similar process looking at the sustainability of IHSS. It was just as difficult as this. Out of that, we got federal funding that had a different name then, but we got the federal match. Every county was mandated to have an IHSS advisory committee We got the option then for collective bargaining. Public authorities were established as an option for counties. There were a lot of things that didn't stick, but what we did then had value, and what we're doing now has value.
Here, here.
That was a very positive note.
I'll be very quick. I'm just going to piggyback on what Lydia and Karen have said, which I think we should not let ourselves, especially if there's areas of very contentious disagreement, those don't have to be, we don't have to die on that sword here. I think we can move past it to other things that we can agree on. And if you individually still want to go with your group and fight for the thing you like, then you still can. So I just think that's another piece to remember.
Okay, great. Who is it that is next? Ellen? Was it Ellen?
I was just going to question whether or not we wanted to individually spend some time and talk about the areas we think are most important. Is that part of the feedback we want to give? Because there are so many recommendations and we've only talked about a few. So is it each of us pick our top 5 or top 10, or how do we getting at that consensus since we're not going to meet in person again?
Great question. And I think that's a good segue for you, Kim, because you had, Nina, did you want to make a comment? No? Okay. Anybody else? Because I think that's the key question, is how we get there, how we get to the big ideas, because we're having some agreement in general on themes. But Kim, did you want to, is there somebody else on the phone that wanted to make a comment? No. Okay, Kim?
Let me make a proposal here, and then let's have public comments. We can hear from the public on some wisdom and reflection on this, and then we'll have the big finish. Right? So what I'm hearing from people is a need to have that big idea. Thank you, Karen, for the 92. This can happen. Not everything happens. What's going to be the next generation looking back and saying this? So what are the big things? But also space for the tension and the controversy. So some prioritization. And so I think the question for this group is whether you want to do those things on Thursday because you have the time shared, with or without the state, whether you want our help with technology to vote and things like that. So we can do I think, hold the time, and then you will hear soon from Susan and Sarah what to do with that time. With Catherine's friendly amendment that 8:30 is much more civilized than 8, so noted. So hold your Thursday morning, but those are the priorities. And then obviously there would be a lot of work done. I mean, this is incredible to have this 25, 30-page document mapped out. It really gives you a lot to work from. And then thinking about what is it you want to bring back on the 19th. Is it this refined? Is it a shorter, big idea piece? And some of this goes into the master plan. I think there's some really good smaller conversations and thinking. Maybe some consensus exercises that Brandy's talked about in the past that could happen to focus our 19th time. That's what I'm hearing. And so if I can pause there and do public comment, we can then come back for the last 10 minutes to sort of hear from the public. I'm really hoping someone in the public has a wonderful, but is that okay if we move to public comment? Okay. So with that, we are going to move to public comment, and as always, welcome on any of the topics we've discussed. We do have several hands in the room, which is wonderful. And any on the, just so we know, are there some queued up? Okay. So and how many mics do we have? All right. Susan, I think I see Jeff and Lorinda and Carol are all ready. And maybe more.
American River College, there we go. Okay, just a couple of quick comments. One on the phrasing for consistent use throughout the document. I'm really trying in everything that I do with my students to more humanize everything and stop saying older adults. So older people and adults with disabilities, that's a distinction between children with disabilities and adults. So I think that might be a suggestion on my part. The confusion around the pathway idea, I just want to put a picture in everybody's head right now. I think it's more that we need to have a map, because people are never going to, they're always going to identify with what they're looking for based on their own individual identity and needs. And so even if we want to have this one pathway that everybody goes down, they're going to be looking for whatever category they are in for support services. So we might have
shared destinations across all the paths, but we need everybody to be able to find their path based on what their need for services are. As far as priorities go, with respect to the core section that you're talking about, the access, I think that's where we make it clear what are the essentials. We need to, in that language of describing what that access is that we really are specific about this is where we want the weight and the money and the effort to go first, right? And let's see, from an out-of-state kind of perspective, there are states who have non-residential based ombudsman. They've expanded their ombudsman program, and let's face it, a lot of the abuse happens in homes where there's no one. And so I think that we need to think about how we might be able to follow one of those models. I think Colorado has that. And then in Arizona, the shortage for RCFEs, they went from 126 nursing homes to 1,800 group homes in Maricopa County alone. You know, it's a huge retirement center. And then they also set a standard so you didn't have to be licensed if you only had 2 residents. It was a different level of expectation so that they could meet that rising need. So I think out of the box, we could probably come up with a way to meet the need if we think about that and look at those models. That's it.
Jeff Tartagia, advocate. I assume you hear me. But anyway, I will start off with saying that in the Engage, make sure the hyperlink and the calendar shows what is going on. I had a problem trying last Monday and last Wednesday, and some of the Marty has been the greatest about providing me when meetings are so that I participate and make. Next thing I will offer public comment-wise is I'm in other silos. I will talk about the homeless. I will talk about the pit and say to you that you look at and see what is missing. Half of your population you right now have, you know you have an adult population of this, and you have for IHS workers, what, 500,000. 10 years from now, how are you meeting those commands, those workforce demands? What are the training efforts? What are the things that you right now, 5 years from now, to what timelines would you lay out for the, should we say, long-term services? And I'm suggesting right now you should put a 5-year timeline on there. And I bring this up because for homeless, they're still working on defining what homeless is so they can track them. How in the world on your adult and quality of the adult in 5 years from now, what should it look like? Putting everybody in nurses' home, you're not going to do that for 2-3 million people. So you need to figure out right now what are the services and what is it to get you to those levels. And I don't see that right now in what you've done so far. But I would also offer my compliment to you is this. Is in less than 6 months, look at what you've done and the team and the effort that you have put in here and made. I wouldn't have believed before that you would have accomplished what you've accomplished right now. So it emphasizes to you guys, you need to have timelines that make it, even if you can't meet them. And the other side of when you finish with this report, talk about the other subjects that you want to add to the master plan on aging. I think that's very helpful, and the public would really like to know those things.
Okay.
Carol Swartzlander, can everyone hear me? Commission on Aging. Before I start, I just want to give you some perspective. Many of you know, but some don't know, that I spent 7 years at agency working on federal grant projects that focused on building infrastructure to support access to information about long-term services and supports to keep people at home and in their communities, which is exactly what you're working on. And kudos to you. This is really difficult, and I know how hard it is, so I appreciate all the work you're doing. My first recommendation is that there is a glaring hole in the document, and that's the lack of options counseling. So the ADRCs, the Aging and Disability Resource Connection Centers, one of their core services is options counseling. And that includes a person-centered interview, decision support, an action plan, and follow-up. So that helps people navigate the system of what currently exists so that they can access the services they need in a timely manner. And I would also suggest that in terms of when you're building out over time, because this is going to be a 10-year plan, I would actually encourage an investment in the ADRC initiative, because the whole purpose of it is to leverage the existing resources that are in a community. So when the partners come together, they do an environmental scan to find out what services are there, what are the gaps. Then they develop MOUs. They do warm handoffs for information and assistance. But with the options counseling, what makes it different is that decision support that they provide. And this is for the middle income. That is also a service under ADRC that's not funded. So I would also encourage you to put funding into options counseling. It will serve anyone regardless of age, disability, or income. Another mission would be state infrastructure to support the ADRC initiative. With options counseling under the federal grant program, we managed to create an infrastructure of training support. So if you're going to have a consistent service across the state, you really need to have an infrastructure to support that ongoing training, both online and in person. And then regarding the web-based platform, part of my project was also developing a pilot LTSS website. So I'm really thrilled to see that as a recommendation, but I would encourage you not to define what the platform should be. So Cal Quality Care may be a good platform, but there are also lots of technological advances right now. So you can make the suggestion, but I would encourage you just to explore all the different options. And then finally, just a point. I listened to the CalAIM in lieu of services webinar last week, and we also had, as part of the commission, we put in to mandate home and community-based services under under Medi-Cal managed care. And they said that federal regulations preclude them from requiring HCBS, that it had to be provided as optional. So that might be a barrier that we need some technical assistance from DHCS to explore.
Alana, you're unmuted. Alana Berger.
Oh, actually, it's Lindsay E. My Hong, but I'm using the Zoom account of Alana Berger. Thanks so much.
Oh, welcome.
Hi, my name's Lindsay E. My Hong, and I'm calling both as an individual who is part of a family that's supported my two grandmothers over the last 5 and 6 years, both relying on paid support, and then also family members unpaid. But I'm also calling as the California director of Hand in Hand, the Domestic Employers Network, and we're a national membership organization of employers of home care workers, child care providers, and house cleaners that support dignified working conditions that benefit both the employer and the worker. Really appreciate the work that's being done by this committee and the Department of Aging and all of the various departments that are involved with this effort. I know it's really big. We are very excited that you're talking about worker shortage. That's really a big issue for our members, streamlining services and navigating the system, as well as the sustainability, the long-term sustainability of the IHSS program. But I also wanted to particularly raise up the importance of addressing the affordability of long-term supports and services. I know that's been on your radar, you've been working on it, and we're excited that you're thinking about helping to patch the big hole that I see, or that we see in the safety net around LTSS with a new LTSS benefit. We do support the creation of a universal LTSS social insurance program that serves everyone, and we know that we're looking at the Washington model, but we're afraid that it just doesn't go far enough. It leaves too many groups out. And so we would be in favor of a social insurance program that includes everyone, includes older adults with disabilities who have already retired and are not, no longer paying payroll taxes, as well as younger people with disabilities who've acquired their disability as a youth or as a child, or are born with a disability. And then, of course, we want to make sure that folks who are independent contractors or are working with ITIN numbers, that everyone's able to participate in whatever program is created, because we all deserve to live and age with dignity. And we believe that everyone should have access to the supports they need to do so. So again, just really appreciate the work that's being done, and know it's a really big lift. And thank you again for your consideration and time.
Thank you. One more public comment? Kiara Harris?
Yes, thank you. I am looking at the draft report, and C8 calls for the development of an equity committee. And I'm just wondering what the status of that formation might be.
Yes, I can give a short update, which is a little bit different, which is the Master Plan for Aging Equity Work Group. The members will be selected in coming days and notified this week. The planning group is meeting again tomorrow. So an equity work group which will inform the deliverables and engagement for the master plan, about a 6-month work group, will be contacted by the end of the week. This is a broader recommendation, if I'm understanding it right, in the report about equity in all aging and disability programs baked into ongoing department and agency and governor level work.
Okay.
I hope that helps.
Yes, it does. Thank you.
Thank you. Hi, is there a caller who's 916-742 to start?
Hi, yes, this is Russell Rawlings, Director of Advocacy at Resources for Independent Living. And I am commenting to say that we need a universal long-term supports and services program. And as mentioned earlier, the Washington model just does not go far enough in terms of who is covered. We need to ensure that people of disabilities, with disabilities of all ages are covered and that no one is left behind. Thank you.
Thank you. Okay. Connie. Connie, are you unmuted? Connie Arnold? Okay. You want?
Thank you. The comment is from Julianne, who's writing on behalf of the Elder Action Committee of Ashby Village, a community of seniors to help all stay in their homes. They're particularly interested in developing a social insurance model, one that covers current retirees as well as those about to retire and or have disabilities from birth.
Thank you. Well, perhaps this is a good time for us to take a minute for Susan and Maya and I to do our very best to humbly channel the public comments we heard in Mountain View on Thursday night. Just very briefly, the Alzheimer's Association, was led by Jessica Rothar, held a listening session, and County Board of Supervisor Joe Simidian kicked us off. And I just wanted to, it was such a moving event. There were all the people and policies and programs that we're talking about where it felt to me were, not all, but many, many, many were in that room with enormous pain around the caring for their partners, caring for their parents, not having money, not having support, not having information, repeated falls, just really a tremendous amount of urgency in that room that we do think big, think bold, work fast, work hard, get this right. And I know we've been in all these windowless rooms with malfunctioning microphones, but I wanted to somehow channel that energy up here. I know everyone here knows that or you wouldn't be here, and you live it every day in your personal life and in your work. But it was extraordinary, and I don't know if Susan, if you or if Maya still on the phone can share some of your reflections on what stuck with you from that night. Maya, you're on the phone? Are you on the phone?
Hello, can you hear me?
Yes, please, please contribute if you'd like, Maya.
Yes, I certainly agree with Kim's assessment. It was a very moving meeting. The things that really stuck in my mind from that meeting, working in the Bay Area, and because this was in Mountain View, wasn't in San Mateo County, but I know these issues are throughout the Bay Area as well across the state. There was a lot about nursing homes, quality, but also access to nursing homes. And then I know because we face this every day, people being turned down because they're on Medicaid and turned down by nursing homes, particularly people with behavioral health issues. And, you know, that's a huge problem in the Bay Area. We don't want people to be in nursing homes, but sometimes people have to be there, and the fact that there aren't enough beds is huge. The other thing I mentioned before was, as far as alternatives in nursing homes, the lack of alternatives because of board and care homes closing down. So I just heard a lot of pain in those two subject areas, and of course the areas that Kim mentioned as well, as, you know, getting access to information and not having, and the affordability problems. But I just wanted to emphasize those 2 points.
And this is Susan. I just want to thank Kim for making the trip with all the work that's going on, and Maya also for you to be there as hard as you've been working. And just 2 thoughts. It was profoundly moving, and a positive is we met in a beautiful adult day healthcare center, and it showed me what's possible all over the state, Patty. And when we were putting the recommendations together into this report over the weekend, as we would write things and move them, I would see the faces and hear the words of people that were in that room, and I would feel good about our work, knowing that people are counting on us, and what they need and want and are looking for is in this report. So.
Is someone talking? Because we can't hear on the phone.
Just to end on the note of hope that the community, while we're always striving to be more inclusive and diverse and broaden, there were caregivers of all ages, a millennial there who was putting his business aside to take care of a family member, a person closer to my age whose sister was flown in from across the country. There were people caring for partners and grandparents, but you said all generations, all languages, lots of different income. So it made me, as sad as it was and painful as it was also very hopeful that this is finally the time where we have so much community energy and community movement. So, thank you for the opportunity to go out and listen, and I hope we gave you just a flavor of what the public comment that we heard out in Mountain View on Thursday night was. It was very, very motivating and hopeful, ultimately. So, with that, thank you for the public comment here, online, on the phone, in the communities. I think we have heard the feedback that there will not be an official LTSS subcommittee meeting in 72 hours. That Thursday morning will be given back to you all for some smaller conversations, some planning. Susan and Sarah, as your fearless leaders, will be in touch about what their thinking is on the best use of that time. Continue to save February 19th. We will still plan for that to be the LTSS subcommittee meeting, maybe a 1-meeting month. I don't want to get crazy. I don't want to get really, but it's short months. To kind of see what the 2.0 version of this looks like heading into the March SAC. So more, is anything else, does that sound right? And you heard all the feedback, everything from working with this document as is to add and edit and restructure, and but also thinking big and also engaging in the controversies, but not in a way that derails, in a way that moves us forward. So that's all. Yeah, Ellen. Yes, I'm sorry. I'm using big. Ellen is saying don't forget prioritization. I'm using big ideas and prioritization interchangeably, and they're not the same thing. So thank you for calling me out on that. Those are different things. So both the big, bold ideas, but also prioritization is really what you're hearing from the group. Susan and Sarah are going to follow up with directions. And but hold the time on Thursday morning. So I think what I'm going to do perhaps is wrap the official meeting, and there's going to be some sidebar calls sidebar discussions among the various subgroups to coordinate the best use of that Thursday morning time. But we will continue with the February 19th meeting and continue scheduling as needed. The document is posted on the website. Comments are welcome. We talked earlier about deadline being Wednesday. Forget the deadline being Wednesday at noon. Comment as you please. The slides, the document are there. Anything else at this moment for the good of the group? Thank you all.